So you can proceed. You are live now.
Hello, hello. Ladies and gentlemen, I welcome you to this Global Dance web series. Now, this episode is on the retina. So we have a galaxy of speakers in this episode. And I'm definitely sure that this episode is going to be very interesting. And we will be listening retina, Dr. Kim, Dr. Sanjay Kumar, Dr. Alkesh Chaudhary, Dr. Sandhya Makhija, Dr. Gagan Bhatia, Dr. Dinesh Tanda, and Dr. Rohit Chandana. So I'm here with my moderator, Dr. Alkesh Chaudhary.
So your audio is broken, sir. It's not.
Voice is not clear.
Mic is not clear?
No, just is broken totally. Hardly can make out what you are talking.
Why the sound is coming broken? Hello, hello. So I'll request Dr. Alkesh Chaudhary to.
There's echo also, lot of echo.
It's okay now or no? Still not clear?
Sir, is this mic clear?
Yeah,
It was
it's
clear.
clear.
Is this better?
Yes, definitely.
Okay, so I'll request Dr. Alkesh Chaudhary to introduce our speakers, and then we'll take up the first speaker from Dr. R. Kim. Dr. Alkesh, please.
You let us know order of the speakers also so that you'll be ready accordingly.
I welcome Dr. Kim, who is working as a senior consultant of Vitreoretinal Services, Arvind Eye Hospital and Postgraduate Institute of Ophthalmology, Madurai. He has undergone fellowship training in vitreoretinal specialty, both in India and later in US. Now he is currently the Chief Medical Officer of Arvind Eye Hospital, Madurai. He has a keen interest in surgical retina and also has a special interest in telemedicine, which has become now demand of the day. He is one of the earlier pioneers to introduce teleophthalmology in India. Arvind Teleophthalmology Network, through its vision centers, sees more than 3,000 patients every day, which is really commendable. His current interest is in using AI for screening diabetic patient for the presence of diabetic retinopathy. Working with Google, he has deployed an AI-based screening tool for real-time use for diabetic retinopathy screening in India. Mr. Surinder Pichai of Google has honored him by nominating his work as one of the best to happen in next 25 years in the Wired magazine. He is currently the Vice President of Vitreoretinal Society of India and also of the Telemedicine Society of India. Dr. Kim, sir, we welcome you, and he will be today telling us unmet needs in the management of diabetic retinopathy. Dr. Kim.
Thank you, sir. I really thank Dr. Alkesh and the Delhi Ophthalmic Society for inviting us for this important teaching program. My interest has always been on diabetic retinopathy, more so in reaching out to people early on. As we all are aware how our country is flooded with the recent 2021 IDF Atlas shows. Earlier, we were thinking it was 467 million globally, but now it's 537 million adults are living with diabetes. In India, if you look at it, the number today is around 74 million, but it's projected to almost double in the next 25 years, which is like a big number. Unfortunately, as we all know, the diabetic retinopathy has no early warning signs, and very often the patients come to us only when they lose their vision. Fortunately, we have very good treatment if identified early on, gold standard treatments. With these like non-center involving, you've had conventional lasers. For today, the anti-VEGF has changed the way we treat our patients. With all that, earlier it was a disease where the vision could be prevented from worsening, but today we can have, with all these new anti-VEGF treatment, we can improve the vision, which is worsened due to diabetic macular edema. In spite of all this, we are currently seeing this disease at a very late stage, very often when the patient loses the vision, and then he comes to us, not before, when it could be prevented from losing this vision. And this is not only for illiterate people. We even most educated people tend to ignore seeing their eyes because of lack of awareness. As you can see, one of the studies by the PHFI had shown that 45% of the patients with diabetic retinopathy attending the diabetic units have already lost their vision before the condition was diagnosed, which means we are doing very little. Ornet India was a large initiative taken up by, started by Dr. Shobha Shiv-Prasad from Moorfields Eye Hospital to create India-centric evidence for diabetic retinopathy. And this was actually 4 of the major institutes, the Mohan Diabetics, LV Prasad, Hyderabad, Arvind Madurai, and Shankar Netralaya joined together to create this with the UKRI, the United Kingdom Research and Innovation Center, with the initiative from Dr. Shobha Prasad, who was the chief PI driving this to identify, and in turn, each of these centers connected with 4 other centers, totally around 20 hospitals were involved in this process. This was across the country, north, south, east, west. And there were a lot of studies that came under this. One of the major initiatives was to do a epidemiological survey of the prevalence of diabetic retinopathy. It was done in a very, very unique way, going into the community and screening the patients for diabetes and then for diabetic retinopathy. It was truly a cross-sectional study where we were able to look at this was the first time a national prevalence study on diabetic retinopathy was done. And it was seen the overall prevalence was 12.5% among the patients with diabetic retinopathy. What is frightening to see is the overall prevalence of vision-threatening diabetic retinopathy in people with diabetes aged 40 years or more was 4%, approximately 300,000 patients, which really calls for an urgent attention to prevent this vision-threatening diabetic retinopathy, which is again a major loss, not just the vision loss, but the economic loss that we have due to this losing vision due to diabetic retinopathy. So the SN Dreams, Dr. Rajiv Raman and team had shown that in their projection, they had projected that we would reach this number in 2030, but the current Ornet India study shows that we already have that number of vision-threatening patients, which means we are losing patients to this diabetic retinopathy in a much faster rate than projected. The prevalence of diabetic retinopathy, and as expected, the vision threatening was increased with age, and it was irrespective of whether the patient came from the urban or rural residents. And the prevalence of diabetic retinopathy in the urban and rural areas. Earlier, we were thinking rural areas was little lower than the urban, but it appears from this study that it is comparable. And we all know that there are very few retina specialists, and they are mostly concentrated in the urban areas. And unfortunately, people with vision-threatening diabetic retinopathy in the rural areas have very little access to care or to even have this diagnosis before they lose the vision. So the prevalence of this vision-threatening diabetic retinopathy in known diabetics is approximately double that was observed in the undiagnosed, newly diagnosed diabetes. But if you look at the newly diagnosed diabetes, 2.4% of the people have already got an appreciable or vision-threatening diabetic retinopathy at the time of diagnosis. That many of these patients were diagnosed as diabetic only through this process, which indicates that we are really diagnosing these patients at a very late stage. And so there should be a lot of screening efforts to be done, more so for people with known diabetes, because that number itself is huge. So screening of diabetic retinopathy should not be limited just to the retina specialist or to the ophthalmologist. We have to find other ways to improve this screening, because the physicians are the ones who see these diabetic patients, as we call as what we can call as opportunistic screening. How do we make them screen these diabetic patients? Because diabetic patients actually go to the physician's office, and they could, by using technology, they could do an eye examination just like they get their blood investigations done. They can also do this primary screening of these diabetic patients, because patients with good vision do not go to the ophthalmologist unless otherwise required. So this is a win-win situation where the diabetologists are able to give value addition to their patients. And recently in the IJO, we have published, Rajiv and team have published about the diabetic retinopathy screening guidelines on how to screen patients for diabetic retinopathy. This is a general thumb rule that we have. Only 20% of diabetics will have any DR at the time of screening. If you screen 100 diabetics, of these only 20% may have vision-threatening condition. That is like 5% of the people. But since we do not know which 20% will have these vision-threatening condition, we have to examine every single diabetic at least once in a year, so that, and then, as I said, the screening should be done at every opportunity, not just when the patient goes to the ophthalmologist. Today, with technology, we can have that process. I just wanted to describe the telescreening. We have been doing this for almost 20 years now, screening the patients in the diabetologist's office, where we have trained the diabetic clinic technicians to take fundus photo using a camera, send a report to us, and our ophthalmologist will see, grade an image and send it. Today, with the use of artificial intelligence, we can do away with the grading process. A simple tool that has come in, which can, within few minutes, is able to give us the status of the diabetic retinopathy, and based on this, the diabetologist can send these patients to the ophthalmologist as needed. As I said, only 20% at any given time may need it. So it is good that every patient, every diabetic patient gets a screening done. So today we have removed the doctor from screening, looking at these images, and the diabetology clinic gets a report using this artificial intelligence tool. They get a report of the diabetic retinopathy status within a minute. And we have seen the performance of AI through multiple validation studies to show that this AI tool is much better than a trained grader or a general ophthalmologist, and it is comparable to a retina specialist, and in some occasions have proved to be better. So using these algorithms reduces the burden of grading these images, reduces manpower, and in the Fission-based DR screening program, they can be easily integrated to scale up the screening, because only then we will be able to screen. As I said, the onus of DR screening should primarily be with the primary care physicians and endocrinologists, and ophthalmologists should play a catalytic role and encourage their colleagues to use this technology to screen every diabetic that comes their way, and refer only those patients who need, or the patients can be triaged using these technologies. So I want to thank you again. I'm sorry for repeatedly stressing on this, but the numbers, as you see, is increasing with time, and we have to find ways to identify these poor patients who may lose vision early on, so that you can prevent this needless blindness due to diabetic retinopathy. I thank you again, sir, for inviting me to be a part of this.
So thank you, Dr. Kim, for the excellent and wonderful presentation. Have shown the importance of screening examination for all the diabetic patients in the diabetic clinic, as well as when they are coming to the ophthalmology clinic. Also, we need to dilate the pupil and then do the proper screening examination. As you have very rightly said that almost 20% of the diabetics would have some other changes in the retina. So it gives us and the message that it's so important to do the diabetic screening in all our cases. Thank you, sir. Thank you very much for the excellent presentation, Dr.
Thank you, sir.
Thank you, Dr. Kim, sir. It was a wonderful presentation. Like you said, 20% of all diabetics will have some evidence of diabetic retinopathy, and 20% of these 20% will have vision threatening. Are there any risk factors or something that this diabetic should definitely undergo fundus examination, or you recommend doing fundus examination in all diabetics, irrespective of stage where they come from?
Irrespective of where every diabetic should have at least
Yes,
one
ma'am.
year an eye examination to make sure their eyes are clean. Retina is clean. Yeah.
Right.
Yeah, Dr. Kim, it was an excellent presentation. Like this telemedicine, what you're saying, like not only the ophthalmologists, other people also should be able to examine. Like the boy is working with me, like he's doing all these fundus imaging and everything. In due course of time, he's just a 12th pass. He has also learned what is diabetic retinopathy, how we diagnose, what are the early signs, where NV, NVD, he can diagnose all those things. So I think even the uneducated people in the periphery, they are trained like this. They are exposed to these type of images frequently. They learn and they help in diagnosis and helping us in early treatment of these cases.
Thank you, sir.
Thank you so much, sir. It was a wonderful experience, presentation and updating everyone for this telemedicine so we can reach to even the remote areas. Thank you so much, sir. Thank you.
So Dr. Alkesh will go ahead with the second speaker, Dr. Pramod Bende. He's going to talk about the bimanual surgery for PDR. So you can introduce him.
I will like to invite now Dr. Pramod Binde, who is a MS from Government Medical College, Nagpur, Vitreoretina Fellowship from Chennai. He is currently as a director, Shri Bhagwan Mahavir VR Service, Shankar Netralaya, Chennai. And I have my past memories with him. So he has been an excellent teacher, excellent human being, helping us all the time while I was doing my fellowship in Shankar Netralaya. He has delivered over 400 presentations, various national and international conferences, over 90 papers in peer-reviewed national international journal, recipient of 7 named orations, reviewer for more than 8 ophthalmology journals, including AIO, IBMJ, APGO, IJO, seminars in ophthalmology, etc. Special interest surgery for ROP, diabetic retinopathy, and combined procedure involving anterior and posterior segment pathology. I had my first paper in ROP, surgical managed from Shankar Netralaya itself. And recently he has got SS Harry Award from VRSI. Congratulations, Dr. Pramod Binde, for getting the award. So I request Dr. Pramod Binde to speak on the topic bimanual surgery for diabetic retinopathy.
Okay, can you hear me?
Yes.
Yeah. Good evening, everybody. At the outset, I would like to thank Dr. Alkesh and the entire DOS team for having me here. So the topic will be today, we are talking about bimanual surgery in a diabetic. So basically conventional vitreous surgery, when you look at, it's basically what we call as 3-port. We have inferotemporal quadrant sclerotomy, we have a infusion line. So typically what you see this diabetic eye surgery going on, removing the membrane. Generally, we have a upper right or maybe your active instrument in your dominant hand, depending on the surgeon, where and the other port, where generally all of us use left hand. So left hand sclerotomy using for a light pipe. So though and usually it's a passive instrument. So effectively, though we use both the hands, one hand remains inactive, holding a light pen, just providing illumination in the eye. So in true sense, it is not really a bimanual surgery. So what is basically true bimanual surgery is basically using active instrument in both the hands. So now basically we need to basic concept is to use both hands for active instruments. So that means we need light source, so we have to have light source somewhere else. It can be either through microscope, through another sclerotomy, or connected to the infusion line, or even to right-handed instrument. Basically, what you are talking about, multifunction instrument as well. So these are three possible options what we can have. So coming to the bimanual vitrectomy for diabetic, basically the advantages is facilitates more aggressive membrane surgery as compared to when you use a unimanual. So this is typically what we used to do old days, 20 gauge cases. So 3-port and 4-port will be made. An assistant used to hold endo-illuminator through that 4th port, and this is what typical surgery used to do. This is again, but the disadvantage here is you are totally dependent on assistant who is holding his light, and if he doesn't show light properly, then you are in really mess. However, we used to manage those days with obviously trained assistant is a prerequisite for all these surgeries. However, with time change in technology, we have now multifunction instrument. This is basically again showing 3-port where this is a 25 gauge illumination along with infusion, which can be fixed as inferotemporal cordon as a conventional 3 sclerotomies here. And as you see here, you get excellent visualization for your bimanual surgery. Now, when you look at this, of course, with the MIVS, you have these 2 clips I am simultaneously showing using bimanual surgery with again 3-port, I mean, with combined light and irrigation. So cutter is used like a scissor, and then a parallel left side video you see exactly same way, the way you cut each attachment or each nail exactly a similar way cutter can be used because of its now reduced gauge of the cutter and much more precision. So showing typically the both ways again bimanual surgery, but one side is a cutter, one side is a scissor doing more or less same function. So you can minimize the use of scissors over a period of time now. Now, when you use another way instead of 3-port, when you use a 4-port surgery, you need to use a chandelier. Now, there are different locations you can use chandelier, whether you can use 1 to 12 o'clock or inferonasal quadrant or inferotemporal quadrant next to your infusion line. Generally, the location is decided by surgeon and depending on where you would like to initiate the dissection. Now, you look at this case, where again, this was actually 20 gauge video. You can see the curved scissor, but here I use the illumination put at 12 o'clock. The reason being I wanted to initiate the dissection somewhere at superior part, so that illumination, when you have it exactly light falls at the base of the polyp where I'm dissecting. If you put somewhere else, probably the shadow of this membrane itself will cast down and block the view, and sometimes your visibility get compromised. So you have a good examination before surgery, decide where you would like to initiate your dissection, and accordingly you choose the meridian where you would like your chandelier to be fixed. Like this is a case where now your chandelier is an inferotemporal quadrant giving good illumination, and you see like I've started inferior part and progressing towards 12 o'clock meridian while cutting, and here exclusive cutter I use again as a scissor, cutting each attachment there, basically taking care on. These were of course post Avastin injection, young diabetic, managed to get almost bloodless surgery. You can make out membrane is almost avascular here. Dissection was not really that difficult, even though membrane was very, very large. And this is like some 18 or 19-year-old juvenile diabetic. We could get a membrane comfortably out, and it was a bilateral involvement. And once this is what final picture, both the eyes at a 2-month follow-up. Patient is holding on well, now lasts almost 4 years. Now, another practical difficulty, however, we have now combined RD, mobile retina, and there is no PVD. So here sometimes there's a lot of difficulty when you try to induce PVD, there's no counter traction and you have posterior entire retina getting pulled up, and chances are there that you may tear the retina rather than separating the posterior highlight. So what you do here is probably use a suction, but at the same time use your light pipe to tap the retina back or hold the retina back. And gently whatever area vitreous you are lifted, you just shoo that vitreous off so that there won't be transmitted traction, and that will minimize the iatrogenic complications. You cannot detach posterior highlight here the way you do in a PVR or RD cases or macular hole cases. We are doing it. So you gently lift it up. Light pipe is not showing here, but what is light pipe doing simultaneously is holding the retina back when I lift the posterior highlight with my cutter suction. So that's why the only disadvantage here is you get only localized area of illumination, but once you intermittently, you can look around to get back to your orientation. Now, same thing, particularly when you are dissecting the membranes and when the retina is mobile, probably sometimes it is difficult to use it, lift it only with cutter. And this is a typical example, I would say, even in MIVS, where you would like to use scissor, extensive membrane, mobile retina, and probably rather than using only cutter, I would prefer here scissor is a typical scenario. So dissection probably is much safer compared to using cutter directly. Another advantage of bimanual surgery, when there is extensive bleeding, and probably if you agitate the blood and if you change again your cutter or other instrument or backflush needle and go back again with cautery, by the time you do that, again blood is covering that area. So this is another advantage. You can have cautery ready in one hand and use another instrument either to suck the blood out or flush the blood away. And as you see there, immediately you can use cautery to pick up those bleeders and stop the bleeding. So to conclude, bimanual surgery definitely have distinct advantages. It provides counter pressure or support during when the retina is mobile, so you have a better control on dissection. Reduce frequency of instrument exchanges throughout through the sclerosis, so that helps to reduce the risk of iatrogenic complication, and also it like you can finish the surgery much faster. So better hemostasis, and that way again you reduce the overall surgery time. So it facilitates more aggressive membrane dissection and hence makes difficult cases amenable to the surgery. So thank you very much for patient hearing. So open for discussion now. I'll stop here.
Thank you very much, Dr. Vinde, for the wonderful presentation on the bimanual surgery, what is basically the actual concept of the bimanual surgery. And I think these days, most of the vitreoretinal surgery is bimanual surgery. Dr. Dinesh, you would like to comment on something?
Surgery is not bimanual surgery. But in difficult cases, bimanual is a technique which makes things much simpler. Life becomes much easier. And fortunately, with the newer illuminating systems, we have adequate light, and you can even though usually even one endo illuminator is enough, but you feel the need, you can even put a second endo illuminator, and you can get even better light. You can have at 180 degrees from each other so that they counterbalance the shadows. Wonderful surgeries, and showing that bimanual can make surgeries which you otherwise think are inoperable, operable. The one point which I'd like to ask Pramod, with the higher gauge instruments, you go to 25 plus and you go to 27. I feel that the bimanual is more difficult because it moves on its own, rather than, because it doesn't have that steadiness which maybe a 23 gauge instrument would have. Do you feel that way?
25 gauge, definitely. I think it's a matter of how you get used to. So most of the cases now we are very comfortable with 20 gauge, 25 gauge. 27 gauge, still all of us are having a limited experience, but 27 gauge, definitely they are flexible, but we need to just modify our technique a little bit subtly, because 27 gauge, probably we need to make sclerotomy straight, more close to horizontal meridian, because reaching 12 o'clock area sometimes is difficult. And again, entry is more not like a two-step, probably a single step incision. So again, you don't have to bend the instrument significantly. So that way, probably you can make it easier. Theoretically speaking, 27 gain probably will have a better advantage because you are being a smaller instrument. Then again, you can have a lesser space between membrane and retina, probably easier to enter in that those spaces, and that's why they will have probably more edge. But yes, subtle change in a technique that all of us, I think, over a period of time with a lot of experience, will be able to come over quite easily. Oh yeah, one more point I wanted to add here. Yes, we talk about 10,000, 20,000 cut rate. But when you want to use these instruments as a scissor, you need to, in fact, cut down the cut rate significantly. Even I use not 10,000 or 5,000, I use some 100 or 200 cut rate with a shaving mode, so that really it works as a scissor and not really cutter and sucking along it. So you have a much better safety because you have much better control on it.
Also, that Dr. Pramod, thank you for those wonderful surgical videos as always. I see many people actually saying that they don't use bimanual because the cutter does everything and they are able to manage any membrane. But I think the outcomes are much, much better as what Dr. Pramod showed in those, heavy membranes that you see in diabetic vitrectomies or combined tractional RDs. I think bimanual makes a lot of difference to the patient, to the patient visual outcomes.
So good evening. This is Dr. Gagan here. I had a question to ask from Dr. Bhinde. So, sir, what is your protocol for using preoperative anti-VEGF for PDR surgery, and what was the time interval that you usually follow?
Yeah, as far as time interval is anything between 3 to 5 days before surgery, because probably again it's because of our surgery schedule. We operate twice a week. So naturally we plan that way. So anything between 5 to 7 days, but even up to 10 days is okay. But if anything beyond 2 weeks, probably we may have to re-inject. You have to be careful depending on how when calibration comes back or rebound, vascular congestion, everything as far as. But what we all know is within 24 to 48 hours, you definitely have an effect of anti-VEGF. And anytime after that, you can plan your surgery. Cases, really, I do not use for every diabetic case. Where you have a florid membrane, probably those are the cases. If membrane, like a long-standing detachment, membrane are already fibrous, probably not. Only vitreous hemorrhage, isolated attachment, probably I don't use. But basically it goes case to case, but there is no fixed guidelines. I think each surgeon has their own protocol. I know there are a few surgeons for every diabetic case, they use anti-VEGF, but probably may not be necessary.
But any protocol that you follow regarding, an on retina and off retina. So sometimes you'll have, the membrane would not be so florid, but you have a retina which is kind of attached. And there are situations where you have a significant amount of TRD. So do you feel that the safety margin goes down with a pre-op in a retina which is attached?
No, again, if you have if a fibrous membranes are there, really doesn't make much difference. Okay, but yes, you think your dissection is extensive and you anticipate that looking at the membranes that they're more likely to bleed. There's no harm giving anti-VEGF. The issue here is you look at the window and basically suppose you feel patient is diabetic status, unstable, things are getting delayed, the patient may not get fitness, then I will hesitant to give injection. So what we do is make sure patient is fit for surgery. So what crunch phenomenon, all those things we are talking about. So if you are operating within a week, I think that factor does not play here. Problem only with when things get delayed, then you are more worried. If more fibrous tissue you inject and then surgery get delayed, then you can land up in problem. And a couple of patients have had a problem, get delayed almost 3 weeks, 4 weeks, and then have a massive bleeding on the table. We really have to stop surgery halfway through, take the patient next second time.
Thank you, sir.
Thank you, Dr. Pramod, for the wonderful discussion, and you have given us the message and answered each and every question. Thank you very much. And now I'd like to request Dr. Alkesh to call upon the next speaker, Dr. Sandeep Grover, and introduce him.
I would like to invite now Dr. Sandeep Grover. He is a professor of ophthalmology and associate chair of Department of Ophthalmology at the University of Florida at Jacksonville, Florida. He is also the director of Inherited Retinal Disease and Electrophysiology Services at the University of Florida, Jacksonville. Dr. Grove received his MBBS and MS ophthalmology degree from India and then completed residency in ophthalmology in University of Illinois at Chicago. He completed fellowship in neuro-ophthalmology, inherited retinal disease, and medical retina from Universities of Illinois at Chicago. He now practices as a medical retina specialist at the University of Florida at Jacksonville, with special interest in inherited retinal diseases and electrophysiology. His research is mainly in the area of inherited retinal diseases and focus on defining the clinical course of disease, visual acuity and pattern and rate of visual loss in retinitis pigmentosa. He is now studying the application of imaging technology and prevalence of psychosocial effect and resilience. Dr. Sandeep Grover has been a very kind person and accepted our invitation to speak on electrophysiology. He has a lot of work. He has been a recipient of Career Development Award from the Foundation Fighting Blindness in 2005 and MOS for Sight Visionary Award in 2015. He received the Achievement Award and Senior Achievement Award from the American Academy of Ophthalmology on several occasions. He was awarded the Exemplary Teacher Award at the University of Florida. He also received the Beals Award for Medical Research twice by Dual Country Medical Society. He has, to his credit, more than 100 publications in national and international ophthalmology journals and more than 150 abstracts in national and international meeting conference. He has also been invited to give more than 70 talks in national and international meetings, some of them keynote speaker. He has written several books, chapters on inherited retinal diseases. Dr. Sandeep Grover, you are welcome to this global DOS web series. And he will be speaking on role of electrophysiology in retinal diseases. Dr. Sandeep Grover, please. Dr. Sandeep Grover, is he online? I think he's not online. Maybe. Okay. हाँ जी फोन कर हेलो आप आ जाओ आपको बुला रहे हैं हाँ अभी आना हाँ प्लीज यू हैव बीन इनवाइटेड how long you will take okay should we call another speaker in between okay we are calling and next will be your turn okay right okay fine.
Yeah, till the time Dr. Sandeep Grover is able to log in and log in with his presentation, I'll request Dr. Alkesh Chaudhary to deliver his talk. and is going to talk on drop nucleus or drop IOL. What next? Dr. Alkesh Chaudhary.
So today will be my topic of management of IOL and nucleus drop. So these are the basically the factors responsible. It can be subluxated lenses, posterior capsular defect, peroperative PCR or zonal dialysis, postoperative external forces like trauma, capsular contraction, small capsular rhexis phimosis leading to accompanying complication can be inflammation, increased IOP, corneal decompensation, vitreous incarceration, residual cortex nucleus fragments, retinal damage, and CME. Symptoms: unwanted optical image, decreased vision, edge glare, diplopia, sneakers of light, halos, photosensitivity, and ghost images. Examination: we examine the corneal status. How is that? Whether to manage it, the things are visible or not. Integrity of anterior and posterior capsule, so as to place the lens if it has not been placed. Anterior chamber, IOP, indirect ophthalmoscopy for RD, CME, vitritis. Our management concept is like total and safe removal of the cortex and nucleus, preserve capsule for IOL fixation, safe and thorough removal of the vitreous from wound and anterior chamber, retrieve IOL without causing collateral damage. Back to front approach is always the best for these cases rather than going from the front. So this is one case like posterior dislocation of IOL. It was in the back with CTR, means zonules are weak. You see, I'll be passing the suture before going inside to fix the scleral fixation IOL. So because CTR was there, so zonules are weak. He underwent a small trauma and whole of the lens got dislocated behind. And see this is the lens lying in the posterior chamber on the retina, removing the cortex, vitreous, and after inducing PVD, you see whole of the vitreous is being removed all around the lens. You see the lens in toto in the back is lying in the posterior chamber on the retina. So we try to remove with the help of a forceps, but it was very slippery. So we modified it with the, you see, small needle, bend it, 25 gauge needle, bend it and lift it, just with like a fish hook technique, brought in the anterior chamber. After making an opening, you see it was so slippery, even with the forceps we could hold it, and went back and again lifted with the same, with the fish hook technique, brought in the anterior chamber. And this time you see is brought in the anterior chamber. This time I use the limbs forceps just to make sure it doesn't go back. So holding with the lead pipe in the anterior chamber, and you see the limbs forceps I'm using. So lens is coming out. So lens is out, and finally the bag is out with the CTR ring. And finally we fix the SFIUL and completed the surgery. This patient got a 6/9 vision post-operatively. Just the only thing, nothing was messed up. Things were managed timely. And so that's very important. So if you don't mess up, don't mishandle, so you can manage these cases. This is another case of nucleus drop. Again, you see the IOL was already implanted in the sulcus. So we are going behind, moving the cortex, lying behind, then the vitreous as much as possible, and the cortical matters lying behind with the vitreous. See, removing the epinucleus, cortex, all around, lying around this part of the nucleus. After removing all this, left with the nucleus part, so making the sclerotomy bigger with the further 20 gauge with the help of a MVR blade and using the phragma tip. So with the help of the phragma tip, rest of the nucleus fragments were removed. And you see everything is clear now. And slightly just tapping the lenses, just centering the lenses in the sulcus. It was slightly decentered. Now this was a case mismanaged. How you mismanage the nuclear drop and how you land up in the troubles. You see all vitreous hemorrhage. So this is my very old video. So used to do with the all 20 gauge contact lens, irrigating contact lens. You see the all vitreous hemorrhage, total RD. So if you run behind the drop nucleus, try to remove it either with wire vectors or anything. So trying to find the nucleus. You see the nucleus is lying here deep into the retinal folds. Hard nucleus, Morgangian hard nucleus, which is lying deep in the retinal folds. So removing all organized vitreous hemorrhage. Then finally, again, with the help of a phragma tip, I got buried deep into the nucleus and brought it in the front. So releasing this nucleus from the retinal folds. See this nucleus is with the help of a phragma tip now, because this all retina is mobile, it becomes difficult to break inside and very hard nucleus. With the help of a phragma tip, not difficult to break inside and in the anterior chamber, and you see finally removed. And did the VR surgery and finally for the retina. So post-operative care, we see for the inflammation, IOP, hypotony due to only choroidals on each follow-up and evaluate the retina. Prognosis is excellent, visual results, and a low rate of complication if proper VR techniques are followed. Late prognosis depend on the prevention of corneal decompensation, RD, choroidal hemorrhage secondary to surgical manipulations. And it is always said prevention is better than cure. So do not run after the dipping IOL or the nucleus and messing up the things which become difficult to manage. You see, like we could manage the cases giving a vision of 6/9, even 6/6 partial, 6/6 also. Do not try another IOL without removing the previous IOL drop. If IOL drop, don't put any IOL. And in case if there is a nucleus drop, even if you want to put IOL, you have to choose the right IOL to put, not like that any IOL which is in your hand, you are going to insert that IOL. Like I removed one multifocal IOL which are dropped. So don't put those multifocal IOLs which you can't center properly. So they are not going to help at all. Do apply extra suture to secure winds to avoid any leaking pores or hypotony. Refer to the retina specialist without any delay. Timely right way intervention will give you the best results. Thank you for your patient attention.
Thank you, Dr. Alkesh, for the wonderful presentation and shown the beautiful technique to how to remove the the dropped nucleus as well as the dropped IOL. So these days, he's coming back. No? Okay. So we'll go ahead with now the previous speaker, Dr. Sandeep Grover. Is he ready now, Dr. Sandeep?
Dr. Sandeep,
Yes,
are
I
you ready?
am ready. Yes, yes.
Yeah, great.
Okay.
So Dr. Sandeep will be telling us on, I have already introduced you to everyone. So directly
you.
you can go ahead with your talk, role of electrophysiology in retinal diseases.
Okay, thank you. Give me one moment. Let me put this in the screen. Can you see the slides?
Yeah.
Okay. And you can hear me fine?
Yes, we can hear you.
Okay, great. Well, thank you. Thanks, Dr. Alkesh, for inviting me to Delhi. Good evening, everyone. And I'm going to share something about the role of ERG in retinal diseases. We'll go over some basics of the ERG recording and then a few cases as to what is the role of ERG in the different clinical conditions. I'm not going to bore you with the anatomy of the eye, but you know, the retina made up of 10 layers. And what is important is the junction of photoreceptors, the rods and cones, the retinal pigment epithelium, and the choroid. That's a very important junction. And the rods and cones are the cells that take up the light first, and then it is kind of transmitted through the bipolar cells, Mueller cells, and then goes to the ganglion cells to the brain. So what is ERG? Well, when this light comes into the eye and strikes the photoreceptors, there's an electrical response that is generated. And this electrical response is really a very small waveform, so that needs to be amplified in the form of ERG. There are many types of ERG, but the two types that we normally do clinically are the full field ERG and the multifocal ERG. So the full field ERG is a diffuse response of all the rods and cones in the retina. Whereas the multifocal ERG, it actually focuses on the central 30-40 degrees, and it is a response generated by the cones only. So what we get in multifocal ERG is only a cone response, whereas in a full field ERG, we get both rod and cone responses. So as you know that the rods, they respond in dark or dim light, whereas the cones respond in bright light. So the waveform that we can record when the light first strikes the photoreceptors, the rods and the cones, it sets up a negative deflection, and that is the A wave. And then when it goes to the bipolar cells, the amacrine cells, the horizontal cells, and the other inner layers of the retina, that sets up a positive wave, which is the B wave. And usually in a bright flash of light, the B wave height, which is measured from the trough of the A wave, is kind of double of the depth of the A wave. So this part from here to there is double of this to this. So how do we do ERGs clinically? We follow the ICEF standards, which is the International Society for Clinical Electrophysiology and Vision. And basically, we are testing the rods and the cones. So you dark adapt the eye, patch the eye for 30 minutes or more, and take them into a dark room. After that, take off the patch, put an electrode, different kinds of electrodes you can use, put an electrode which is connected to the computer, and then they are in front of a bowl. And the first is a dim flash. So let's look at these recordings. So first is a dim flash, which is a pure rod response, diffuse rod response, which appears like this. And then you have a brighter flash, which is still rod predominant because they are in the dark still. But there is, because of the intensity of light, there are some cones that get kicked in. And so that is the kind of response you get with a dark adapted white flash or a bright flash. Then we let the patient sit in the room for 10 minutes exposed to the light with the room light on. So that suppresses the rods and brings on the cones now. And next we again stimulate the retina with a white flash, and you get a negative A wave and a positive B wave. That's the cone response. And you will notice that this response is less than the rods because there are about 120 million rods in each eye, whereas there are only about 5 to 7 million cones in each eye. So the response, the waveform is less. And then the last, you want to know the maximal cone response. So you do a flicker stimulus, and you get multiple waves. So basically, those are the 4 recordings that we look at. And depending upon the condition, depending on what you see in the retina, you correlate that. Multifocal ERG, which, as I said before, is just the cone. So you don't have to dark adapt a patient in this, and just needs to be dilated. And you take and then look at a checkerboard. And this is what multifocal ERG would look like. So the central, so this is basically showing you the sensitivity of the retina. So the fovea is the most sensitive. So you get a peak, and that's the right eye, left eye. And then as you go away from the fovea, the sensitivity goes down, and this is the perifoveal area. So this is how it should look. Now, someone, let's say, for example, who has plaquenil toxicity can look like this, where initially there is perifoveal suppression, and then finally the fovea can be affected too. And you can see the peaks are blunted. So what are the clinical applications of ERG? Well, we can use it for diagnosis purposes. We can use to talk to the patient about the prognosis of a particular disease. It is definitely being used more and more now for the natural history of disease, as well as for treatment trials, because there are so many treatment trials that are coming up. So here is a patient who is a 12-year-old boy with decreased vision in the right eye for 2 years, and was diagnosed as having retinal degeneration. And there's an older brother who is supposed to have Stargardt disease. So the vision was down in the right eye, about 2200 or 660. And the left eye was also not normal. The vision was not normal. And he was a myope with some astigmatism. There was an APD in the right eye, interestingly. So this is the retinal degeneration. So as you can see, this diffuse retinal degeneration in the right eye. And the fields showed some superior and nasal defect. And this is the left eye, which does not show the degeneration. It shows some subtle findings in the fovea, like spoke-like pattern. And so we did the ERG. The top 2 are from the right eye, which has much more degeneration, so you can hardly record the waves. And if you look at the bottom 2, they are from the left eye, which is relatively good. And this is the dark adapted bright flash, where you should get a A wave and double the amount of B wave. And what you see here is the A wave is good, but the B wave does not go up as it should. So this is called a selective B wave reduction, or an electronegative ERG, because it stays negative, it doesn't go positive. And this is seen in about 15, 16 conditions. But one of them is juvenile X-linked retinoschisis. So this patient actually had juvenile X-linked retinoschisis, except that the right eye had much more degeneration from the schisis. Here is another one. There's a 15-year-old boy with poor vision, and the color vision was down as well. What you can see is macular atrophy, and this is in both the eyes, bilateral. The visual acuity was again 660 or 2200 in both the eyes. So here is the norm. On the right side is the normal ERG to the various stimuli, and then the left side is the patient's. So just focus on the photopic white, which means the dark light adapted white response. You can see that it is hardly recordable, whereas it should have been like this. So light adapted means cone response. So cone response is definitely down. And if you look at that flicker, which is also a cone response, you can hardly get a recording. If you look at the 30-minute dark adapted white stimulus response, you see there is a negative A wave. So there is a response, but it is less than the normal response. So electrophysiologically, you see that there is both rod and cones involved, but cones are involved more than the rods. And so you make a diagnosis of cone rod dystrophy in this patient. Whenever you see a poor central vision, poor color vision, and sensitivity to light, always think about cone rod dystrophies or cone dystrophy. And the difference between cone and cone rod is electrophysiological. Had the rods been normal and the cones were down, it would be cone dystrophy. This is another 14-year-old boy, looks like has a similar picture of macular atrophy in both the eyes. I'm showing you only one eye, but both the eyes have the same picture. Again, 2200 vision, and the color vision was down too. What you do see is around it some flecks in that area. They're very subtle, but you see the flecks. And so we did the ERG, and the ERG was normal. So the rods and cones were normal in this patient. And I did not do the fluorescein angiogram. I usually don't. But if you did a fluorescein angiogram in this case, you would see a silent choroid or a dark choroid indicating Stargardt disease. Because Stargardt disease, at least in earlier on, the ERG is totally normal. This is just to show you the silent choroid. This is how you see the fluorescence in the background. And here it is blocked because of the lipofuscin and the RPE in Stargardt disease, which blocks the fluorescence. 8-year-old boy, this was interesting because 8-year-old boy with sensitivity to light and nystagmus, 2200 vision in both the eyes. The eyes look pretty good, except for hypopigmentation. So we thought about achromatopsia because the patient had nystagmus. So we did the ERG, and you can see the rod response was good. The cone response was not recordable, which is expected in achromatopsia. So 1 year later, this patient comes and says, the mom says that he's bumping into things. So we repeat the ERG. And what we see is that the rod responses have started to go down. You see this compared to here. The rod responses have gone down as well. And so we had to change the diagnosis to cone rod dystrophy. So the fundus did not change except the symptoms. And then the ERG kind of tells you that it's not achromatopsia, but cone rod dystrophy. So that was for diagnosis purposes. Here is a patient who is 40-year-old, Hispanic male. He knew that he has a diagnosis of retinitis pigmentosa for at least 25 years. His vision was still excellent. He showed these pigmentary changes in the mid-peripheral retina along the vascular arcades. Same with the other eye. The fields showed this posterior ring scotoma in one eye and in the other eye. Otherwise, the peripheral fields were good. The ERG was down, but still recordable. That was the rod, and this is the cones. And 10 years later, the vision was still 20/20. The visual fields were about the same. The ERG was about the same. So that tells you about the prognosis, that this is it's a good prognosis. The limited kind of retinitis pigmentosa, which is mainly along the arcades, gives a ring scotoma kind of thing, and very slow progression. And then you have the natural history studies. So I went to clinicaltrials.gov and put in natural history inherited retinal diseases in the United States. And 21 studies are being conducted or were conducted in different inherited retinal diseases as a natural history. And we are participating in a couple of those natural history studies where you do an ERG and in the baseline and then do ERG in 4 years to see what is the change. And lastly, it is helpful in treatment trials, which again is one of the endpoints of retinal function. But remember that there is a lot of variability of ERG. So if you do ERG, we did ERG in successively 6 weeks apart, and we found that they could differ by as much as 20%. So that needs to be taken into account when you design treatment trials. And that's all I have for ERG and its role in retinal diseases. And thank you again. I know last week was Holi, so I put that in there. Thank you very much.
Thank you, Dr. Grover, for the wonderful and very simplified presentation of the ERG. I think this is the first time I heard a talk on the ERG which was so simple and so understandable. So you made so easy so that we could understand. I think almost all of us could understand what exactly ERG is and what exactly ERG does. So thank you, Dr. Grover. Thank you very much. And your presentation was beautiful and wonderful presentation. Thank you very much.
Thank you very much for inviting me. Sorry, I was delayed. I'm in the operating room today, so.
So we have some questions.
Sure.
Thank you, Dr. Grover, for a wonderful presentation, because this area is mostly gray area for most of us. Especially now we've left institute, we've come in practice, and we really forget these things. You've made this so refreshing and simple for us. You know, it's a good recap for us. Thank you. Nice
Thank
to
you.
have you here.
Thank you. It used to be a gray area for me too, till I worked with a mentor.
Thank you,
Now I
sir,
love it.
for your excellent presentation. It was so simple to understand and very nice, informative also. Thank you so much.
Thank you.
Thank you
Thank
very
for
much.
being with us. Thank you. And next speaker.
Now we'll go ahead with the next talk is by Dr. Sandhya Makhija. And Dr. Sandhya is going to talk on selection of intravitreal injections in retinal diseases. So Dr. Alkesh, introduce Dr. Sandhya.
Dr. Sandhya Makhija is a renowned vitreoretinal surgeon, and she's a graduate and postgraduate from Maulana Azad Medical College and Guru Nanak Eye Center, and she's a VR consultant at Sant Paramanand Eye Hospital and Sham Eye Hospital. Dr. Sandhya Makhija now is going to give us talk on selection of intravitreal injection in retinal diseases. Dr. Sandhya, all yours.
Thank you, Dr. Bhalla, Dr. Prasad, and Dr. Alkesh for having this wonderful platform to have this retina meeting. And I thank all the members who have logged in and all the members and friends who are here with us today. So this topic was given to me in various retinal diseases and how do we choose intravitreal agents. So it's not a straightforward talk. Little, you have to come down to a lot of points. So still, I'll try to make it clear. And I would like to have participation of my friends here, friends sitting here. So just to brush up on DME, I don't know if some young residents, some young people have logged in, so probably it will be helpful for them, but I can't see any young people who are logged in. So it's a leading cause of blindness in lots of young adults, and basically caused by combined mechanism. Two mechanisms have been postulated, mainly VEGF mediated and inflammatory mediated. If we talk about inflammatory mediators in diabetic retinopathy, so all those diabetic vascular alteration will cause intraretinal fluid leakage and hemorrhages, ischemia, which in turn would cause macular edema, visual loss, cottonwool spots, and neovascularization. In other way, it will other cycle, it will also release various kinds of VEGF and inflammatory mediators. These inflammatory mediators will cause even more adhesion and increased permeability, and again more cytokine exposition, which in turn makes this kind of a vicious cycle. And here all these anti-VEGFs will come out, and lots of factors like interleukins and all, which will cause even more of neovascularization, leakage, cotton spots, and macular edema. So it goes on and on this way. There are various kinds of VEGF, VEGF A, B, C, D, and some placental growth factors. And out of these, VEGF A is most abundant in retina. And metabolic stress in retina causes upregulation of VEGF A, which causes angiogenesis and increased vascular permeability, leading to bleeding and leakage of fluid, and so visual loss. So this is the interrelation between the VEGF and increased BRB, which in turn causes macular edema and fluid retention. Macular edema is a common feature of lots of retinal diseases, whether it is uveitis, occlusion, venous occlusions, wet AMD, or DMEs. So as I told you, all these diseases, they in turn causes increased macular, increased inflammation. It may be little less or little more in various diseases, like uveitis is more of inflammatory cause, venous occlusion, it's more of vascular leakage and little bit of inflammation and neovascularization. Both is happening in wet AMDs. It's basically neovascularization happening and some amount of inflammation. And so you can see these colored things. And in diabetic retinopathies, all these things are happening probably in equal proportions. So all these diseases will cause retinal macular inflammation, edemas, and all these factors. So our management options probably will point out to the same things. What anti-VEGFs are doing, they're ultimately slowing down visual loss. So approved anti-VEGFs in ophthalmology are, okay, if we go from ranibizumab onwards in 2006, ranibizumab was approved. Earlier, only Vijaptamab was an option. Ranibizumab was approved for wet AMD, DRs in diabetic macular edema, macular edema from retinal venous occlusion, and myopic CNVMs also. Then came aflibercept way ahead in 2011. It got approved for wet AMDs, DRs in diabetic macular edema, and macular edema for retinal venous occlusion. Then came brolucizumab in 2019, which was approved for wet AMD, now also got approval for DMEs. So if we talk about medical management options, we have lasers, intravitreal injections, intravitreal steroids, and of course, there are other intravitreal agents. But if you talk, laser has its own limitation. It was a mainstay of DME treatment till recently, but there are certain limitations of lasers, like it induces scars. So these days we have much better option that we go for. But if we see laser, probably these days in the era of today, it is applicable for focal photocoagulation maybe, but mainly for PRPs, people are doing lasers now. Anti-VEGFs are injected in vitreous cavity, decreases macular thickening and edema. It has lesser adverse effects, but the effects are transient and it requires repeated injections. There may be little complication associated with any intravitreal injections like cataract, glaucoma, ENDOF, like TAS-like reactions. It cannot be used in vitrectomized patients. First limitation in CVAs, MIs, patients with stroke or pregnancy is questionable. Recalcitrant cases, cumulative cost is little high. Little poor patient compliance sometimes builds up because of injection fatigue. There are various studies, so I'll just give you a crux of these various studies which have pointed towards the benefits of anti-VEGFs. So these Rise and Ride conclude that ranibizumab rapidly and sustainably improved vision, reduces the risk of further visual loss, and improved edema in patients with DME. And these results were maintained through 36 months. Resolve and Restore also almost said the same thing. And on this basis, Lucentis had obtained marketing authorization for the treatment of visual impairment due to DME in many countries after 2011. DCR.net protocols 1 to 2 year results said improvements in ranibizumab arms, both prompt and deferred over IVT and other laser treatments, but no clear benefit of adding prompt laser. Further, 3 years results at focal or grid laser treatment at the initiation of intravitreal ranibizumab was no better and possibly worse than deferring laser treatment for more than 24 weeks. Then 5 years objectives were awaited, and they were basically to know whether combination of laser with anti-VEGF yields additional value, whether BCVA improvement achieved at 1 to 3 years follow-up are sustained over 5 years, and how many injections are required in follow-up years. So basically 5 years follow-up also said that mean visual acuity gain is 9.8 letters or 7.2 letters in ranibizumab plus deferred versus ranibizumab plus prompt laser. So they all showed better results. Now, just benefits, effective variety of studies proving efficacy in terms of BCVA and macular thickness, like I've just shown you. They're faster acting. There are certain risks like cardiovascular events, frequent injections are required, and risk of ENDOF and TAS and everything. Coming to steroids, it targets inflammation, stabilizes the junctions between endothelial cells. Foveal hard exudates, some people say they just melt away or they move away. Side effects and complications are same as any intravitreal injections, and but they can be pretty much managed. So basically, maybe we can say steroids are good for pseudophakes with DME, phakic people who are not compliant, phakic patients with center involving macular edema, and with hard exudates. So they can be a good choice in DME. It circumvents multiple injections because the effect is little longer lasting. It takes care of inflammatory mediators as well as some VEGF or more reduction of macular edema and better improvement, some studies say. Again, the benefits and the risk are more or less the same. Risk like cataract and IOP increase, but pretty much manageable. Eylea is a different family altogether, like we were talked earlier in case of Lucentis and Avastin. It's a fusion protein, binds VEGF-A with higher affinity. According to protocol T study, they say in more severe cases, aflibercept is significantly more effective than other two anti-VEGFs in improving visual acuity and reducing central thickness in OCT. Then biosimilars, we have an option. Biosimilars are near identical copies of innovative biological or reference products which do not have a significant difference in terms of efficacy or safety. They have a potential to basically reduce the cost of treatment up to 30% without compromising on dosing interval. So just to summarize, what to inject? Anti-VEGF, maybe people who can pay. I mean, of course, for steroid also you need paying people. Patients with PDR, DME, clear lens, glaucoma, maybe we can opt for anti-VEGF. Patients with steroid, patients with macular ischemia, foveal hard exudates, cystoid changes, a pseudophakic patient, and patient who is refractory to other kinds of treatment, maybe we can think of steroids. So broad guidelines. Okay, I think I'll just go on to this slide. Probably this slide will summarize all till now, the practical things, all that I have said. Like you see a patient with macular edema. The first thing one should look for a glucose control, diabetic complications and comorbidities have to be looked for. Look for visual acuity, best corrected, do a complete eye examination, biomicroscopy, OCT and FFA. Then if you see visual acuity less than 5%, there's a decrease of less than 5%. Maybe you can go in for observation. If macular edema is not center involving, maybe you can go in for a laser. Now, if you have a patient, a symptomatic patient with center involving macular edema, and the patient has no vascular disease, the first line probably would be an anti-VEGF. You can think of Ozurdex also, but first line anti-VEGF, I would say. Then you can think of anti-VEGF or some other anti-VEGF or Ozurdex as a second line. And if there is uncontrolled glaucoma, do not consider steroids or Eylea probably. And if the patient has a cardiovascular disease, then you go in for a Ozurdex as a first line probably. If not Ozurdex, then you can go think of any other anti-VEGF or probably laser. If second line therapy doesn't work, and or if chronic patient, consider Eylea or an ILUVIEN implant. Patient has been vitrectomized, Ozurdex probably will be the probably only choice. And if there's a tractional macular edema, a VMT kind of thing on OCT, of course, a pars plana vitrectomy with membrane peeling, and then we can add steroids, an implant later on. So probably saying the same thing. Okay, now I will just show you some clinical scenarios, and maybe Sir can add to, Dr. Dinesh Talwar is sitting here with us, and he can add to things. Now, suppose you have a picture like this kind of patient, diabetic retinopathy, you do an FFA, you see this kind of picture. So this is a non-proliferative, probably not a very high-risk patient. You don't see a lot of capillary occlusions. You can just go in for a metabolic control. 49-year-old lady, poorly controlled type 2 diabetes for 10 years, both eyes has severe decrease in vision. And you see this kind of picture in the right eye. This is the right eye I'm showing. You can opt for a, this patient has been lasered, had a focal laser earlier, and now she has a macular edema like this. Left eye shows also pretty much similar picture. Probably will go for a first line anti-VEGF therapy in her case. Next, you have a case like this. This is the right eye, this is the left eye. Left eye shows frank proliferation with vitreous hemorrhage, and right eye also shows macular edema. And this kind of macular edema with these kind of ARM is also there. So most likely, no, I would say that we should do an FFA in these kind of cases. Definitely want an FFA because you want to know the status of the right eye. Left eye, you know, it's a proliferative retinopathy. So do an FFA. Most likely there will be a lot of non-perfused areas in the right eye, and then go in for a anti-VEGF first in the left eye, and most likely you'll have to go in for an anti-VEGF in the right eye also, or maybe a PRP depending on what findings you see on FFA. Next, you have a patient, NIDDM patient like this. This is the fundus picture. Moment you do an FFA, you see, okay, she gives a history of laser. There are laser marks already. She's been lasered earlier for a PDR somewhere else and some years back. You see still more areas of non-perfusion here. CNPs are still there. There are old laser marks. So in this case, maybe we can just plan a further PRP because it is quite a silent eye. So we can just plan a further PRP in this case. Same case, if you look at the other eye, there are laser spots already, but here on FFA, we see frank neovascularization happening and there are leakages. So definitely we would like to go ahead and inject her with anti-VEGF and then do a PRP a little later. Then we have a case like this here. Patient is a case of NIDDM, visual acuity 6/9. On FFA, there are some focal leaks and OCTs show some hard exudate here and there, but these hard exudates are a little away from the fovea. We can very well plan a metabolic control in her. And if these leaks increase, then probably we can go for a focal laser and watch this patient for some time. Then again, a case of again a case of NIDDM. This is the fundus picture, and moment we do an FFA, we see neovascularization. This is an IRMA here in the nasal quadrant. We go ahead and inject anti-VEGF here, and then we can plan a sectoral PRP in this area of IRMA later. A case of fresh vitreous hemorrhage. This patient comes with a history of loss of vision just for last 3 days. A diabetic patient, not a very good controlled diabetes. So moment we dilate and see this patient has a fresh vitreous hemorrhage. Here we have done FFA basically to document, of course, because we see it's a fresh vitreous hemorrhage, but a lot of times we have to document and we have to show this patient also that, okay, you have a vitreous hemorrhage, you have this leak. So we are giving you this treatment. Plan an intravitreal anti-VEGF and start a PRP as the hemorrhage starts resolving. And if the hemorrhage doesn't resolve, maybe beyond a month. In fact, these days we just wait for about 2 weeks or something, and we go in for a vitrectomy if the hemorrhage is not resolving. So this another case. This was quite some years back in the initial times when we started doing OCTs and started doing intravitreal treatments. So this is the baseline OCT, and we gave 3 monthly injections of Lucentis, and this patient was very well stabilized even till 10 months. Another case, previously laser proliferative diabetic retinopathy. We have already given anti-VEGFs in this case, and recurrent edemas. We gave more, second injection was given and pretty much stable. After 2 months, started having little pockets of edema and fluid accumulation again. Ranibizumab was repeated after 3 months. So one ranibizumab had been given earlier when she presented. At 2 months, 1 month, sorry, it was given once more. And then at 3rd month, it was repeated. This is the picture 4 months. And again, some cystic spaces had started to come up again. So here we decided to implant Ozurdex in her case. And she was doing pretty well. Another case, okay, here we implanted Ozurdex, a 55-year-old gentleman with type 2 diabetes. He was pseudophakic, started having macular edema, so pseudophakic, so we gave first-line Ozurdex in him. Pretty much stable. Another case, this is a 65-year-old lady. Right eye had a regressed PDR, left eye with severe NPDR. She had DME both eyes, more in right eye than left eye. And right eye had been already focal lasered and given Avastin 3 times earlier. And this was the macular edema. So we opted for Ozurdex for her. The macular thickness initially was 840 microns. So we gave first Ozurdex as a first line in this case when she presented to us. So I have a lot more cases, so you can always tell me to stop when I need to stop. So
Yeah, now,
this-
Sunday, you can summarize now.
yeah, okay, okay. So this kind of tractional edema, I just want to show you where any intravitreal injection will not really help. So we have to go in for a pars plana vitrectomy with membrane peeling. Then we can implant an Ozurdex later. So in this case, like we did a vitrectomy and implanted Ozurdex, and this patient was doing pretty fine. So, okay, so I will just summarize. So current treatment landscape revolves around like all these therapies, basically intravitreal therapy, corticosteroid implants, and laser photocoagulation. So we just have to juggle up in between all these three types of therapies just to find out which patient will be suited better with this, with what kind of treatment. So careful coordination between lasers, anti-VEGF, steroids, or surgery. And I think still the most important things remains metabolic control. That we have to emphasize to all the patient that whatever we do, metabolic control has to be done, and the patient has to follow up with their endocrinologist for their best diabetic control. Thank you.
Thank you, Dr. Sandhya. That was nice presentation. You nicely summarized the role of anti-VEGF. There is a question for you from Dr. Reshma Padmaram from Karnataka. Do you prefer anti-VEGFs for rebleed cases?
For rebleed, yes, why not? That is the only option we are left with patient with rebleed.
Okay.
I mean, rebleed after vitrectomy, vitrectomized eyes. That's what she wants to
The
ask.
question is only, yeah. If Dr. Reshma Padmaram, you are there? I think he means after in the rebleed in vitrectomized eyes.
Yeah, but
Yeah, you can.
yeah, okay. If suppose we take the first scenario as a non-vitrectomized eye, so we have no other option. We have given one anti-VEGF and we wait for some time. Probably if we see some clearing, it's clearing in some areas, then we can go ahead with another injection. Otherwise, the best thing is you take the patient for surgery. We plan for vitrectomy and removal of the clot. But if we are seeing some areas which are clearing and we can manage with maybe, one more injection and some more PRP, then only we can plan for a second injection. Otherwise, we plan for vitrectomy. Second scenario, when we talk about vitrectomized eyes. Vitrectomized eyes are like a lot of patients in our early years, we used to see a lot of rebleeds. So we just ask the patient to maintain their head elevation and maintain their metabolic control. So a lot of times they used to settle down and the blood used to clear. But these days we have an option. We can go ahead and have an injection again, maybe a 1/4 dose or half dose of anti-VEGF Lucentis, Eccentrix. We can wait for some more time. Otherwise, we can go in for an air fluid exchange.
Hello.
Dr. Dinesh, could you highlight some points on this topic?
I think if the first thing, I mean, since we are not clear which category of patients we're talking about, if you've got a patient who has a rebleed following a scatter laser, PRP, then yes, if you can consider using an anti-VEGF but after you've checked out whether you've done adequate laser. If there is inadequate laser, you may need to augment your laser also. So you have to complete your laser. More often than not, I find that the lasers are inadequate. So the first criteria is, do you have an adequate laser, which is defined as laser spots of 1/2 burn diameter between adjacent spots, and the area from the arcades covered up to the aura now, not up to the equator, but beyond the equator. So if that is done and you have bleeding, and especially if it still allows you visualization, maybe you should do a fluorescein angiography. If you can get an idea that there are persistent neovascular fronts, it's definitely worth giving an anti-VEGF, and if required, giving more laser. And if you are sure that your laser is adequate, then there's no harm at all in giving an anti-VEGF. In cases of a rebleed following a vitrectomy, first thing is conservative. You don't have to immediately rush in with with an intravitreal injection. You first watch. I would give a patient a week, 10 days and see whether he's improving. Not he's going to become okay, but he starts improving. If he starts improving, you may not need to give an anti-VEGF. If it's not improving, whenever I do give an anti-VEGF, I tell the patient, if you don't improve or if you deteriorate, we may have to take you up for a surgery. So any patient being given an anti-VEGF should always be mentally prepared for a surgical intervention also.
I think
Yes.
one point that I would like to add, because it's a very generalized question, so I think sir has like kind of elaborated. But one very general rule that I follow, that if I don't see, I won't inject. So if the vitreous hemorrhage is dense enough that I'm not able to see the retina, then I will not inject in a non-vitrectomized eye. In a vitrectomized eye, if I have not done the vitrectomy and I don't know how much of remnant prolif is there, then I would again not inject. I would rather either wait or go for a vit lavage and then go in. So if I don't see, I will not inject. That's the golden rule that I think that should be a general message. And obviously case-based case, as sir has very rightly explained, I think case by case we can go ahead. But as a general phenomena, I would not inject if I don't see.
Thank you.
Yes, I
Thank you,
think,
Gagan. Thank you, Dr. Sandhya, for
I just want to add, sir has raised a very good point, rebleed after laser. So many times, we see this kind of case scenario that moment we do laser, immediately next week the patient would come back, मेरे को तो hemorrhage हो गया, आपने laser किया, मुझे hemorrhage हो गया. Even despite we do best of lasers, still like we have lot of anterior area which is left, which we cannot see during the laser. So probably these days white fields, they really help us in this way. So
If you need to.
yes. So this is a very good point. Maybe we can give this other takeaway message to really look for the more of anterior areas, probably which are still
There's
unreached.
one question for Dr. Sandeep Grover, if he's there. This is from Dr. Sachin Pandhare from Maharashtra. There is a 12-year-old boy having color blindness. Visual acuity is normal, both eyes. Fundus is also normal. And there is history of retinitis pigmentosa in paternal grandfather. Is ERG going to be helpful for him? Because parents are worried about developing retinitis pigmentosa in him. Will ERG be helpful in such a case? Dr. Sandeep, are you there? No, I don't think he's there. The question for Dr. Alkesh from Dr. Anshu Arora. Would you prefer to fragment a brunescent nucleus or deliver it through anterior route after complete vitrectomy? And second question is, in a non-dilating pupil, would you prefer to fragment a brunescent nucleus or deliver it through anterior route after complete vitrectomy? And the second question is, in a non-dilating pupil with doubtful capsule integrity, what secondary IOL would you prefer?
Yeah, the first question, like intermittent cataract. Earlier, we didn't have it.
Very hard cataract.
A dark hard cataract, if it is a complete, we prefer to complete nucleus, complete cataract is there, we prefer to remove from the anterior route because we may not be able to break inside. And the choice of IOL, we have lot. We can use the retrovirus, we can use the scleral fixation, and we can use the mainly these two lenses I prefer, either scleral fixation or retrovirus.
Thank you, Dr. Alkesh. And now we'll go ahead with the time constraint. Our next speaker is Dr. Gagan Bhatia. Dr. Gagan is going to speak on imaging in retina. Dr. Alkesh will introduce Dr. Gagan.
Yeah, Dr. Gagan is basically working as a vitreoretinal surgeon with the Shroff Charity Eye Center and Sarvodaya Eye Center and Sarvodaya Eye Care and Laser Center. And his keen interest in medical imaging, surgical retina, diabetic vitrectomy, secondary IOLs, and microsurgeries. He has been recently awarded as a Best Video Award in the EURetina in 2022 in Hamburg, Germany. He's passionate about is using technology as effectively as possible to help patient and caregivers, and is actively involved in development of managing EMR software for healthcare. Dr. Gagan Bhatia.
Yeah.
To speak on the imaging and retinal diseases.
Good evening, everybody. I would first of all like to thank everybody here at the panelists and the speakers for joining us today. So I have a very broad topic to talk on, and which is imaging in retina, and I hope I'm able to do justice. But obviously we'll have to get some flow into the talk. So we'll be talking about how imaging has changed the way we look at the retina. So there are obviously there are many diseases which can which manifest in the retina, and they all need adequate imaging to be diagnosed as well as prognosticated. And this was the first diagram which was drawn by Van in 1853, and this was a time when hope came into action for retina. So the basic imaging tools that we follow are FFA, OCT, OCTA, and ultrasounds, which but we would be focusing on FFA and OCT, OCTA. So this is what we were used to, and this is what we were taught, which was the central field, and you do a imaging and you'd see the arm retina time and the flow of the dye. And when we were looking at a diabetic patient, we obviously had these 7 fields where we were telling the patient to look up, down, left, right. But then why this when we can have this? So this is a wide field image of an Optos wide field camera. And this is based on the SLO based system and uses 2 ellipsoid mirrors to take. So the first part of the top would basically on ultra wide field imaging in retinal disorders. So this concept was also has been published initially by Wessel et al, where they did kind of say that when we are just using the 7 Amsler's grid pattern chart of imaging, we are basically missing out on a lot of CNP areas and a lot of NVEs. And so this was the conventional way of doing a fundus fluorescent imaging, whereas the newer ways on the right side, where you see that we are missing out on a lot of CNP areas as well as the new vessels. This was again so as I was talking about vessel study, so around 3.9 times of non-perfusion, around 1.9 times of neovascularization is usually missed when we go for standard imaging. Diabetic, I still remember when we used to use the flash camera, and small pupil used to be a very big problem, and so it was more of focusing on the outside light on the cornea than seeing anything inside the retina. But that problem has been taken care of with ultra wide field imaging. Coming to the second vascular problem that we face is retinal vein occlusions. I remember the time when, when you have very subtle non-ischemic CRVOs. So by definition, it should not have too much of CNP. And usually with the standard photograph, we would not see these CNP areas which we visualize in the periphery. And so this is the same patient with this similar kind of an image. So if you see that if we frankly treat these, do a scatter or targeted PRP for these patients, they do fare better than non-treating them. PHCR is obviously a disease which is a disease of the periphery, and I think this there are various speakers who have talked about this, that peripheral imaging has really benefited the treatment of PHCR. Coming to pediatric imaging was definitely not something which was possible with conventional photography, and with the new with these kind of instrumentation, obviously there is fixation is easier, and obviously you look at a balloon inside and you get an image, so it's more child friendly, and also there is no problem of fixation of going up, down, left, and right. So we did a study in our own center, and this was the data, and we kind of collected data, and it was quite comparative to even other places. FEVR condition again, which kind of gets picked up only in the periphery, and wide field imaging has really helped that. And this is again wide field imaging guided PRP, and this can also be used as a protocol for documentation. Again, this is advanced form of FEVR. ROP was one disease which was basically out of question to image, at least as a documented photograph. It was based on FFO and also based on based on FFO or based on our clinical acumen, and there was no charting that was run for the patient per se. And definitely, I think even medical legally, if we are able to kind of chart this and we can document this, I think this would really benefit everyone. This was the initial picture. The initial picture was for a 6-year-old boy, and this is basically for a 26 weeks child. And this was published by us also. And this was basically we call it the flying baby imaging. So you hold the child on the Optos machine and you can get images like this. And this can be shared with the patient because they know that what we have done and how the disease can progress. Then uveitis is not my forte per se, but this we took a shot at the periphery with uveitis also, and you can actually image almost till the pars plana, and also helps in again doing a PRP. CSR is definitely a disease which has changed with imaging. I think the knowledge that we had about CSR is also changed with the disease, and it definitely gives beautiful images, especially with the track and everything that you see also on autofluorescence. This was just a chance discovery. I never knew that we could image through gas. And so this was one of a chance discovery that we had. Now coming to the other thing that we have in our armamentarium, and one of everybody's favorite, which is OCT. And I think OCT has gone through various stages, and so now we have basically from time domain to Fourier domain to now to the SD-OCT. So this is what we used to learn, and this is what we used to kind of know. And I remember when I was learning OCT, I never knew which layer I was looking at. But then now I think it's much more simplified, so we can go layer by layer, though obviously the understanding of every layer also makes it a little more complex. We have definite nomenclature which have come up. We have ORTs, CFAN patterns, drill, and HRDs, which are all biomarkers which have come in because of the advancement in OCT and our understanding. So I think the talk on, so now that we've talked about wide field imaging on the FFA, then why not just talk about wide field imaging even in the OCT, and why not go deeper and wider with OCT as well? So now we can obviously take around 16 mm of scans and a 3 mm depth. And when we talk about the B-scan OCT, then even OCT angiography has become wide field now, and much more deeper. And you can actually go for a 22 mm scan with a 12 by 12 pan, which is basically 5 images joined together. So PDR. So PDR, obviously, OCTA does help when I still believe that FFA, dye-FFA is the standard, but then patients with PDR always have concomitant comorbidities, and probably peripheral imaging with an OCT angiography does help. So you can see these world kind of appearance of new vessels in the periphery, in the temporal periphery with CNP areas, and these do go away. So this was just a comparative slide to see that when the leakage stopped on an FA, the network also regressed on a OCT angiography. So it can be kind of documented real time. And same is with vascular occlusions. You can very well pick up these peripheral CNP areas. Featureless retina, again, there was nothing that can be seen on the retina, but there's a whole lot of information that comes on OCT angiography wide field image. And it is not that OCT angiography does not pick up small NVs, but it is definitely an investigative tool which has to be handled with patients. You need to go back to the machine. You need to kind of slice those cuts again and study the angiogram before you give your definite report. And if you actually go through a VR interface lab, you can pick up a very tiny NV also, which does regress. And this was again documented where the NV did regress on the B scan with a flow pattern and also on the NFAS image. This was another, subject which was taken up by Wang et al., where they kind of studied the vascularity flow pattern based on the CNP images that they got, and we tried our hand at it, and this was the image that we got with new vascular with the NVD. So this CSR, as I even said before, I think wide field imaging and even the recent advances in imaging in retina has definitely changed the way that we look at CSR. So if you see at the left, the image on the left with the autofluorescence with that tract, and you look at the B scan, I think the only message you would say is stop smoking, go do yoga, sit on a mountain, decrease your stress. But then if you look at the middle image, and you look at the OCTA, you pick up a network. So I think the way that we look at CSR and the pachychoroid spectrum has definitely changed the way we look at CSR. And I don't think that yoga and all is finally, not something which is now the only forte of treatment for CSR. I never knew that multifocal CSR multifocal CSR this is the way it does present, but didn't know that you could also pick up networks in a multifocal CSR patients as well. And this patient we picked up in both eyes. And this is a big CFAN pattern which did respond to treatment. PCV, I don't think that OCTA is definite for everything. I think people are picking up, do say that, we picked up a polyp on OCTA, but I don't think so. I strongly believe that ICG still is the main form of treatment of diagnosis for PCV, because OCTA is not based, so basically the variable flow pattern is not something which OCTA can pick up, and polyps are dynamic lesions. And secondly, even the segmentation projection, basically the segmentation that you do is not possible because they usually present with PEDs which are of variable height. So I still believe that ICG is the primary diagnostic tool for picking up polyps, though yes, BVNs is something that does get picked up better with OCTA. So this is, yes, wide field imaging again does pick up extrafoveal polyps also, or a large BVN. And this was again documented by us for one patient where he had a peripheral polyp and this was picked up. This again, but then OCTA also increases the confusion. So where it kind of increases the confusion is where you see these BVNs, the patient is still under treatment, but then the BVN is increasing, right? So we don't know how much to extend, whether you extend 6 weeks or 2 months. If I look at the FA and I look at the OCT of the patient, the B scan, this patient is quite stable. So I can probably extend to 2-3 months, but whenever I extend, the BVN increases, right? So this is one question that needs to be answered, that whether we are picking up and whether this will actually progress to a PCV, because ultimately at the end of the BVN, we might get a polyp. So this is a question which still needs to be answered. Best vitelliform, again, this was just the egg story for me earlier, but then with the advent of OCTA, I think we started picking up networks there also. And IJT, again, IJT was the only thing that I used to tell the patient, oh, you have an ILM drape, cannot do anything, please go home. Vision dheere dheere kam hoga, and it should stay stable for most of the time. But then these are again active lesions that now that we know that we can pick up networks even in a IJT. Pachychoroid neovasculopathy, I think, is a disease which has been coined because of wide field imaging and because of Swepsot, OCT, and pachychoroid spectrum. And this is definitely a disease of reality, and this does respond to injections and should be picked up. And I think this, if you see a picture like this, at least for CSR, I truly believe that if somebody has the armamentarium to kind of image it, should be imaged properly, because there are many CSRs which can be treated much more better nowadays than what we were doing earlier. This was again a chance finding where we saw a little bit of pigmentation in the middle of the drusens and we picked up this beautiful network. Coming to surgical use. So this is one of my favorite topics, which is surgical intervention, and Swepsos OCT definitely helps. So basically what I'm trying to amplify in this diagram is that as Dr. Bhinde had told earlier, finding the right plane in PDR surgery is very important, and vitroschisis is the main element that you need to see. So it is more important to study these scans, and definitely can only be studied in a scan where you don't have too much of hemorrhage. But it is better, it is obviously important to go under where the gray arrows are and not fiddle around between the blue and the gray arrows. And wide field imaging again helps us to document. It helps us to show the patient what we have done. So the right image is post a PRP, and we can probably show the patient what what we have done and what we are expected, what it would be the expected outcome in the right eye as well. So again, when we go see the image on the right, and so we go back to our machine, do a scan, and go through all the cuts and see where would be the right plane of entry into the hyaloid, and what would the best possible atraumatic way to remove the membrane. This was again, this is basically again for about imaging for this thing. This is just an image where, I showed a patient to show him that how his retina looks now after detachment surgery. And that small bubble is basically a gas bubble. This was again a thing by chance. This was just 3 days ago. This patient was referred to me for a laser by somebody, and they said that they have lattices in both the eyes. And the patient had 2-3 opinions regarding lattice and prophylaxis. And when I saw, I just had this feeling that there is something not right with this. The vascularity is something different. So basically, we did a wide field imaging, and we were able to see a FEVR. This is another tool which I use, which is basically post macular hole surgeries. So post-op 1 day, you can actually see the hole close on the gas, because the Swepsos OCT has the clarity to go even image through gas. This is again a patient. This imaging, how it helps is basically this is a localized retinal detachment. The patient has the macula on. They obviously say ki mera ko kuch hai nahi, kyun surgery kar rahe ho? So the earlier example I used to say is, okay, go jump on the trampoline. When you have a problem, you will come back. But then now we can show them, and then we can also show them what we did, right? And this is an interesting picture of a graph. So this was a retinal graph which was taken from the superior nasal quadrant and put over the macula, where this was a recurrent RD case which was referred with a large eccentric macular hole. So I think, to conclude, I think imaging has definitely revolutionized the management of patients. It helps in better documentation. It definitely, AMD is something which has also changed with imaging. And I think Dr. Dinesh is going to take up this topic, that topic next. And I think it also, imaging also helps us, especially in the retina, because it's not something that the patient can see. So I think that connect with the patient becomes much better, especially because we have patients who have been on long follow-ups. So I think imaging does help in making a connect with the patient. And so this was a line which I wrote yesterday. So we are coming, I think the newer thing is a 24 mm scan, which is possible in myopes with an add-on lens. So this was a line which I wrote yesterday, was even a myopic view needs to have a wider spectrum. Thank you.
Thank you very much, Dr. Gagan, for the excellent presentation and beautifully shown all
Thank
the.
you.
So we'll take the discussion later, and I'll request Dr. Dinesh Talwar. So he's going to talk on management of wet ARMD. So Dr. Dinesh Talwar, you all know that he's the consultant with Center for Sight, and he has been in RP Center AIMS associate professor, and we were actually together in RP Center for a long time. One of the very good friend, and he's one of the renowned retina surgeon in India as well as worldwide. So Dr. Dinesh, you all know that his talks are always looked after. Like when he talks for any subject, he explains each and everything so beautifully. So we are looking forward to today's topic, the treatment of wet AMD. Dr.
Thank
Dinesh.
you, Dr. Prasad. And thank you, DOS, for inviting me for this talk. Age-related macular degeneration is a condition we expect will become more and more common as the socioeconomic status of our population rises. But before I go forward, this is my disclaimer. And this is the financial disclosure, which is relevant for this talk. Now, exudative ARMD is not a single disease. Contrary to what people may think, CNV due to ARMD can be predominantly classic, minimally classic, or occult. And the occult form of the disease also has three different forms: the late leakage from an unknown source, fibrovascular RPE detachment, or a serous RPE detachment. And different patients behave differently. We know from the Marina and Anchor study that sustained treatment with anti-VEGF agents can end up giving you sustained gains in visual outcomes over a long period. But this is monthly, extremely intensive, and exhausting for the patient and the doctor. The SUSTAIN study showed us that not only can you get good results, but the problem is that with different patients, you need different regimes. Some patients may need 5 or more retreatments after the loading dose, whereas others may be all right with just 3 loading doses. So it varies from 3 doses to monthly treatments for any particular patient. So this demonstrates the need to individualize the treatment. Fortunately for us, we have a lot of drugs available, whether it's ranibizumab, both as the innovator and biosimilars. We have bevacizumab, aflibercept, and brolucizumab now. And of course, another drug expected to come soon is faricimab. What is the optimum treatment for a patient? That depends on not only the efficacy, but also safety, ease of use for the patient and doctor, and the intervals between treatments. Keep it in mind that the most important thing, while we talk about balancing efficacy with safety, the most important thing to consider is safety. You are not going to treat any patient where you think that safety is compromised. What about the factors which influence the visual outcomes? It depends on depends on the intraretinal fluid, subretinal fluid, and sub-RPE fluid. We do know from post-hoc analysis. This is the VIEW 1 and 2 trial, which showed that if you have intraretinal fluid at baseline, it impacts the BCVA over a period of time. Not only is the baseline BCVA less, but also the gain in vision is much less. But more importantly is this data from the EXCITE study, which showed us that when new intraretinal cysts occur early after a loading dose, they are associated with a subsequent BCVA decline. So the later the intraretinal cysts appear, the better it is for the visual prognosis. The longer the lesion is kept dry, the better it is for his visual outcome. Pooled data from the Hawk and Harrier study showed us that the more the stability, the better is the visual outcome. So if there is a lot of fluctuation in the thickness, if there's a lot of fluid which keeps on coming and going, the visual outcome is very poor, just to average of 2.1 letters. But if there is very minimal fluctuation, less than 27 micron over time, these patients have almost 10 to 11 letters of visual gain. We also know that SRF is less harmful than intraretinal fluid. Patients who have intraretinal fluid are more likely to have a decrease in visual outcomes, and especially when the fovea is involved, the outcome is even worse. This is the most relevant study for us, which tells us whether fluid makes all kinds of fluid make a difference to the outcome or not. So here in this study, they took the patients who had the highest, 25% of patients with the highest mean intraretinal fluid volume or subretinal fluid volume or PED volume, and compared those 25% of patients with the rest of the 75% who had less fluid. And what did they find? In each of the groups, regardless of whether it's intraretinal fluid, subretinal fluid, or pigment epithelial detachment, the visual outcome is better in patients who had lower levels of intraretinal fluid as compared to those who had higher levels of intraretinal fluid. Now, how should you treat your patients? Lots of methods have been given, whether it's monthly, PRN, 2 monthly, quarterly, treat and extend, but the ones which are followed most commonly are the PRN and treat and extend, and we will talk about those. We know from the Pronto, Sailor, and Sustain trial that for PRN treatment, monthly follow-ups are important. They are mandatory, in fact. You need stringent guidelines for retreatment, like any loss of BCVA of more than 5 letters, any OCT evidence of new fluid, any increase in the central retinal thickness, any new macular hemorrhage, and even if the surgeon feels, hey, wait, no, I think it's worse, even that is an indication for treatment. When you come to treat and extend, basically the objective is to keep the lesion dry. And once the lesion becomes dry, you keep on extending the intervals between the treatments by 2 weeks, or some do it even 4 weeks. Any recurrence that occurs, you again decrease the interval by 2 weeks or 4 weeks, and again try to dry the retina. In the presence of persistent or stable fluid, the conventional treat and extend does not extend the interval, but we will talk about that later on. And remember, if you have pigment epithelial detachment and there's no SRF or intraretinal fluid, then you can extend the interval because this doesn't respond. The Altair study was more aggressive in their way of, more conservative in the way they extended. They shortened the interval if there was persistent fluid also. Not only when there was increasing fluid, but also when there was persistent fluid. They maintained the interval only if the fluid was decreasing. And they extended the interval only when the lesion became dry. So this is a very conservative way of working. In my opinion, the treat and extend regimes, which we use commonly, they are more proactive, they need more number of injections. And in our socioeconomic conditions, it's possibly a good option for patients who are one-eyed or who are stable but not dry. That's a little different from what is being followed in the West. The wait and extend or monitor and extend allows for increased intervals in the follow-up in the presence of an inactive disease. So this reacts to the disease. Disease I, we treat. Disease is not there, we don't treat. This is the PRN form. And this is best option for two-eyed patients in whom the lesion becomes dry, because it doesn't make sense to keep on treating if the lesion is dry. But we need to evaluate this further to see whether which is going to turn out to be better for us. As far as which drug is optimal, if you look at the efficacy trends in type 2 CNVs, even ranibizumab is very effective. So you don't need to go for the most effective drug in every, the newest entrant in every condition. In type 1 CNVMs, aflibercept is better than ranibizumab. But even if you see the, if you consider the CAT trial, even monthly bevacizumab can dry a lesion. So it is not that you can't dry the lesions with bevacizumab, but you need to give it monthly for a long time. Brolucizumab is possibly the most effective for drying fluid, whether it's subretinal fluid, intraretinal fluid, or RPE detachments. As far as safety is concerned, both ranibizumab and aflibercept are equally safe. Bevacizumab, we've had episodes of cluster endophthalmitis, which is not to blame the drug really, but the conditions we work in. Brolucizumab, we have a 1 in 200 added risk of intraocular inflammation and a 1 in 400 risk of inflammatory vascular occlusions, which you have to factor when you go in for treating. And if you have a systemic event, a recent MI or a recent stroke where you need to give this drug, the only drug we know that works safely is ranibizumab 0.03 milligram, 0.3 milligrams. That's the only that safety was shown in the Sailor trial. Now, how do we actually approach a patient? You give the first 3 injections, assess at month 3, lesion is dry. Now it's dry, you have 2 options. One is a treat and extend, where you extend the intervals between treatment and monitor every 4 weeks. And then you go up to 12 weeks with ranibizumab or 16 weeks with aflibercept. Or the alternative is you do monthly follow-ups, treat when there's a recurrence. That is a PRN treatment. So let's see now. You've done this, you come to month 3, lesion was dry. If it is dry, follow up for the next 3 months, monitor and extend. And if you find that the lesion is still dry at 6 months, now you increase the intervals between the follow-ups from 4 to 6 weeks to 8 weeks, 10 weeks, maximum of 12 weeks. 12 weekly follow-ups will continue as long as this patient lives. The alternative is to do a treat and extend. If there's a one-eyed patient, you don't want to take any chances, you don't want to have recurrences. And if the patient can afford it, then you can constitute a treat and extend for this patient. If a recurrence occurs, you give the injection again and then monitor monthly after that. If over the next few months you don't need to give the injection, you know that your intervals are increasing. If you need over a period of time, you know that this patient is needing the injection at 8 weeks. You can bring your interval to 7 weeks. So it's a form you can shift from PRN to treat and extend after you've gauged what interval you need for an individual patient. And in patients who need a PRN treatment, say less than 8 weekly, this is a patient where aflibercept should be considered. Maybe you'll get better results. The other group of patients at month 3, they're not dry. You've given 3 loading doses, still there are some cysts. Now you give for another 3 months and you find in these 3 months it dried up. If it's dried up, you go to the first paradigm, the first algorithm, where you can go to monitor and extend. It has not dried up. Now what do you do? Now this is where I propose something a little different. This is the place where you know you can't do better than this. So increase the interval between treatments from 4 weeks to 6 weeks, then to 8 weeks, then to 10 weeks, then to 12 weeks, as long as the fluid does not change. If the cysts are the same, the subretinal fluid doesn't change, you can extend your intervals till 12 weeks for ranibizumab or 16 weeks for aflibercept. Now, when should you switch? If your patient is on ranibizumab and you are needing an injection frequency less than equal to 7 weeks for a recurrence, it recurs every 7 weeks, consider a shift to aflibercept to see can you get a better result. If your injection frequency with aflibercept is less than 7 weeks, now this is the patient you should consider a switch to brolucizumab. If you have a patient who's stable, he's not dry, he's stable, and you're needing monthly ranibizumab, again, you should consider a shift to aflibercept. And similarly, if you have a stable lesion, but it's not dry, and you're needing to give aflibercept every 4 to 6 weeks, here again, you should consider a switch to brolucizumab. And the last situation is you give brolucizumab, it didn't become dry at 4 weeks. Now, I don't want to give the brolucizumab every 4 weekly. So what I will do is the next injection I give will be of aflibercept. And then at 8 weeks, if there's still some fluid, I will give brolucizumab at 8 weeks, bringing down the risk of getting a second intraocular inflammation in these patients, because increasing the interval seems to help. But don't fret if your patients can't afford brolucizumab and aflibercept and everything. There's a study which showed that a comparison was done of ranibizumab, aflibercept, and bevacizumab. And you know what they found? Over a long time, make no difference in visual outcomes or the number of injections, regardless of which drug was used. In fact, the OCT analysis also showed that it made no difference which over a long term, which agent was used. Overall, the same number of patients, the same proportion of patients had drying of the subretinal fluid and of intraretinal fluid. So what made the difference? What made the difference was the number of injections given. The more the number of injections given, the more the time the treatment was continued. The more persistent you were and the more regular you were, the better the visual outcome. So what makes a difference is your perseverance and the patient's perseverance, not which drug. That makes a difference in certain small number of patients. But as a large group, as a society, don't fret if you can't afford the most expensive drug. In fact, in this study, which came out in 2021, it's called the FIDO study. They only used ranibizumab. And over a period of 7 years, with 4 to 8 week kind of dosing, they got 43% patients maintaining better than 612 vision. And overall, 2/3 of the patients got better than 618 vision. So imagine these results are possible. These are among the best results you could possibly think of over a long term. We're talking of 7 years here. So what is important is persist and persevere. Not just, don't say, I can't afford, my patient can afford only bevacizumab, so what will happen? No. Persevere with bevacizumab. The basic principles for AMD treatment are no tolerance for fluid. But if I can't get the lesion dry, then I accept the minimum fluctuation that I can. Intraretinal fluid, I don't tolerate at all unless it's completely unresponsive. So if I say, oh, it's a little bit is okay, it is actually the fox calling the grapes sour. I couldn't get the grapes. I couldn't dry the lesion. So I said, well, thoda sa chalega. Now, if there is subretinal fluid up to 100 micron, you may tolerate. But that again, tolerate if it is not drying up. Sub-RP fluid, especially if you're using ranibizumab or if you're using aflibercept also, usually will not dry up. So don't run after sub-RP fluid. If it dries up, great. If it doesn't dry up, forget it. Leave it alone. But increase in fluid is not to be tolerated. The key lesson is aggressive treatment is the way to go. Monthly follow-up, not monthly treatment. Just monthly follow-up is enough to improve visual outcomes, because then you will treat the moment the lesion occurs. Greater the number of injections, more intensive and longer the follow-up, better the visual outcomes. You can start with initial PRN and shift to treat and extend after you gauge how many injections the patient needs, but have a high index of suspicion, treat aggressively when needed. Ladies and gentlemen, eternal vigil is the price for maintaining vision in patients with CNV. Thank you very much, ladies and gentlemen. And thank you very much to this audience because it gave me eye contact with somebody.
Thank you, Dinesh, for the wonderful, wonderful presentation. And this was a delight to see the talk on AMD, which for us, the people, those who are not the retina person, it's just eye opener, how the AMD is being treated by the retina specialist. And it's really, yeah, yeah, that's right.
Like a
story,
coming out.
So Dr. Dinesh's talk is always, you see, because wherever he's talking, I'm always there. And it's so interesting and so learning, and you achieve so much after his talk. Thank you, Dinesh. Thank you very much. Thank you. So any questions, please? Yeah.
Sandeep Grover has also appreciated his presentation. So he's there seeing your presentation. Sandeep, you are there online?
Yeah, I am.
Yeah, Sandeep.
In between the cases, I could listen to his presentation. That was excellent, Dinesh.
Thank you.
You know, a lot of people are aggressive about giving injections, but I think you set the tone right. And that's important.
Thank you.
Yeah, yes, Anil. Yeah.
After you had your trial for intraretinal fluid for 8 injections or so, you can try to make the retina dry and it doesn't become dry. So instead of changing to a different anti-VEGF, would you give a trial for Ozurdex?
No, you know,
Because
Ozurdex is,
inflammation may be at play.
yeah. So see, this is one of those subjects which we don't have the answer yet. It's possible that some of this may be CME component and may respond to Ozurdex, but that before you come to that stage, when you call it recalcitrant fluid, you should have tried something else first. So you should have tried aflibercept and maybe even brolucizumab before you say that this was. If I'm not getting a response to anything, then I may consider this as a one-off thing, not as a message to be tried.
And one more, looking into the same thing. So by trying the aflibercept or brolucizumab, we may be going to 6 months or 6 to 8 months cycle before we can know that it's not working at all.
No, but you will know, for example, if you're on aflibercept, over a period of 3 injections, you know whether you're getting a response or not. If you're not getting a response, you know you would need to. More often than not, it is not you don't get a response. It is you get recurrence, but that is part of the disease process. So, you know, I mean, what happens is, unfortunately, most of the times what is happening is people will give an injection and then say, 2 mahine ke baad aana. Okay, 2 mahine ke baad aana. How do you know that this patient needs 2 months? First follow up 4 weekly. Your 2 months comes after that. Only when you find that you gave 4 weekly, 4 weekly, nothing happened. Now you can say not responding.
I think one point that I'd like to add with CNV, I think sir is, I think connected everything, but just as a general pointer, I think one very, general term that is used is you will get fine in 3 injections. I don't think so. I think AMD, we need to understand, is not a short-term disease. It's a long-term disease and it's a long-term commitment. And the 3 injection is just a loading dose.
Yeah, once again, I didn't say 3 injections. I said 3 injections is after your loading dose.
Not for the,
but this is after the loading dose.
Yeah.
Your loading dose is separate.
Yes. So,
and you could have a patient who responds in the first, now that you mentioned that, once in a while, you'll get a patient who responded in the first injection. Now, you don't know whether this is the end point. So you do need another injection. So for me to say that, look, this patient did not need 3 loading doses, I have to have 3 OCTs, which are 2 consecutive OCTs, which have not changed and which are normal. If they are normal and not changed, then I can say that, okay, I'll stop you on second. And that will happen in a myopic CNVM mostly, not usually in a AMD.
Yeah.
No, I don't give, I give aflibercept as a first line in occult CNVM. not in and in a patient with a type 2 CNVM, I normally give ranibizumab.
What
I
about
start with ranibizumab.
PCV?
In PCV, I prefer to start with aflibercept. I only use brolucizumab as a second line rescue therapy. I give the biosimilar as a biosimilar. Ranibizumab is ranibizumab, whether it's Eccentrix or it is that depends on the patient's mindset. If he wants the imported one, he takes the imported one.
Okay. So I think that was a wonderful presentation, sir. A lot of things, the concepts became very clear. What about, like you said, sir, the intraretinal fluid is not to be tolerated at all. And subretinal fluid, you said up to 100 microns after you have treated and it is not going away. You can
so first,
but what about sub-RP fluid, sir?
Sub-RP fluid, you don't bother.
Don't bother about it.
See, sub-RP fluid is only to be, so if it goes away, then if it's coming back, you consider whether you want to treat it. But if it's not going away, you don't chase it. Okay. The only drug which actually removes sub-RP fluid very effectively is brolucizumab, but that doesn't change the vision outcome. And it doesn't change the disease process as of now. We don't know whether this is, you see, I would run after our sub-RP fluid if it was going to change the disease process. You know, if it is ki sub-RPD settle ho gayi, so disease cure ho gayi, then it makes sense to give it,
It's not.
right? But it doesn't happen that way. Okay.
Thank you, sir. So now I'll invite Dr. Bhuvan Channa, and he's going to talk on aflibercept in the management of PCV. Dr. Bhuvan Channa is head and senior consultant VR services at Bharti Eye Foundation and Hospital, and is fellow Vitreoretina from University of Bern, Switzerland. He is ex-senior resident from RP Center AIMS and ex-associate professor from UCMS GTB Hospital. He has several publications in international and national journals, and is also co-editor of a book titled Video Atlas of Vitreoretinal Surgery, several presentations in international national conferences, and has been invited as a guest faculty to deliver lectures in national and international conferences and PG teaching programs. Dr. Bhuvan Channa, audio, sir.
Yeah, good evening, sir. Good evening to all the chairperson and to the and all the panelists. So I think Dr. Dinesh had covered most of my topic. I'll be discussing mostly the role of aflibercept management in PCV. So I'd like to thank DOS for inviting me for this presentation. Is my presentation visible?
Yeah.
Okay. So I'll try to keep it short because I think it's already post dinner time. So for PCV, as Dr. Dinesh also managed the first line of treatment, mostly which we are doing now is aflibercept, and other anti-VEGFs are not so effective. Brolucizumab is effective, but it has the concern. So still, as a first line therapy, many retinal surgeons are not using it. So coming to PCV, it is mostly present in the older age group, and it's more common in the Asian population as compared to the Western population. Most of the studies, in fact, have been done in Japanese eye. There is a bilateral involvement of about 10 to 20% in most of the patients with PCV. So what is PCV? It is a part of this disease spectrum, which is known as pachychoroid, which has been discussed by previous speakers also. It involves a diffuse choroidal thickening with dilated outer choroidal vessels and severe thinning of the inner choriocapillary layers, or there could be focal choroidal thickening with dilated middle and outer choroidal vessels. So it is a spectrum of disease which involves the PPE, the pigment epitheliopathy, CSC, leading to a neovascular membrane, which is known as PNV, and then polypoidal choroidal vasculopathy. So PCV can be classified into a active or a quiescent one. Active could be exudative, in which most of the fluid is serous. It could be hemorrhagic, in which there is presence of subretinal or sub-RP hemorrhage, or it could be a mixture of both. And one is quiescent. Quiescent has a polyp, but there is absence of any active lesion of any intraretinal hemorrhage or any fluid or hemorrhage in either of them. So that is a quiescent PCV. So ICG was considered as the gold standard tool. It shows the hyperpermeability of the choroidal vessels, showing dilated choroidal vessels in this disease, And you can see these hot spots, these polyps, which come in the later phase of the disease. So ICG is a very important tool for the detection of the CNVM if there is a presence of a subretinal bleed in a PCV. So this is just the same thing. The polyps, they leak slowly and there may be presence of a hypofluorescent area around them. So these are the polyps, and the gold standard is ICG. But however, with the use of with OCTs and OCTA with Octas, the use of ICG have really reduced, especially during the COVID times. So as I said, with OCT also, we have got a very high sensitivity of about 85 to 90%, although the specificity is slightly lower. So these are the classical pictures. If there is a tall peaked PD, there is a thumb-shaped large PD, there is a double-peaked PD. So these are the signs that there is a high probability of presence of a PCV. So now coming to aflibercept and PCV, the study which was done was a PLANET study. So the PLANET study is an interventional randomized study which studied the efficacy of aflibercept monotherapy with or without rescue PDT. So initially the patient received 3 monthly doses of aflibercept, and then they were randomized into 2 groups. In one group, the aflibercept was given 8 weekly, and in the other group, along with aflibercept, a rescue PDT was given. And then the patient was monitored. In between, if they needed any rescue treatment for a PDT was given, and the aflibercept was reduced to 4 weekly. So the primary endpoint at 52 weeks was the vision, and similarly the study was extended up to 96 weeks. So when did you need a rescue therapy? When the vision was less than 73 ETDRS letters, or the best corrected vision changed. There was a loss, a no change, or an insufficient gain of 5 letters, or a gain of 5 letters and less than 10 letters, and the investigators felt that a PDT would benefit the patient, or if there was a recurrence of a persistent fluid or new fluid which was present. So if this was not present, no rescue treatment. If these were present, ICG was done. If they were active polyps, then a rescue treatment was given. So the PLANET study showed that if we did a aflibercept monotherapy or we did a combined therapy, the visual outcome at 52 weeks were almost same. The gain in letters were almost same. And at the end of 96 weeks, aflibercept was slightly better as compared to added PDT. However, the difference was not statistically significant. So majority of the patients which received aflibercept monotherapy did not show presence of any active polyps at 52 weeks and 96 weeks. So 81% of the patients did not have any active polyps at the end of 52 weeks and 82% at the end of 96 weeks, as compared to 88 and 85, which is not again statistically significant. So by presence of non-active polyps, we mean that the polyps are either regressed or the polyps are there, but they have no activities present in that. So more than 30% of the patients which received aflibercept monotherapy showed a complete polyp regression at 52 weeks and 96 weeks. So in both the groups, the polyps were regressed in almost same, approximately 33 to 44. Here it's 44% and it reduced to 29% in the combined group. So again, this is not statistically significant. With aflibercept monotherapy only, we were able to achieve more than 30% complete regression of the polyps. So this efficacy was maintained in the second year also. So as we can see in both the groups, the number of injections of aflibercept are almost same, whether PDT was given or not. Even at 52 weeks and even from 52 to 96 weeks, the number of injections were same. And the number of rescue PDTs which were needed were also same in both the groups. Over 80% of the patients showed no evidence of polyps at 52 weeks and 96 weeks, which I also highlighted earlier also. And a proportion of patients with dry retina on OCT, which it showed at 86% at 52 weeks and 83% at 96 weeks were seen in the aflibercept monotherapy, and which were comparable with in the aflibercept plus active rescue PDT. So this. So is rescue PDT needed or not? So at 12 weeks, only 6% of the total patients, they met the rescue PDT criteria. So this study just highlighted that aflibercept monotherapy is as effective as a patient on monotherapy with rescue PDT. And according to this study, the need for rescue PDT was not superior in a patient who did not receive any rescue PDT and continued with aflibercept monotherapy. So this monotherapy with aflibercept, it avoids the side effects which are present with the long-term PDT. PDT can be associated with decreased vision in year 2 to 3 because of the presence of the scarring, collateral damage, or even the presence of a recurrence of the existing or a new choroidal vasculature. So most of these effects are avoided by the use of anti-VEGF monotherapy. So again, this is just a repetition. Aflibercept monotherapy is very simple regime. There is no need for all the equipments for PDT, and although they're not available right now in India also. So this is another study, the WALT study, which showed 65% of the patients had complete regression of the polyp with aflibercept monotherapy after 12 months. So these are the number of the eyes which showed a complete regression. 26 eyes showed a complete regression out of 42 eyes at the end of 3 months, and 26 eyes continue to show the complete regression at the end of 12 eyes. So Apollo study was another study in which 97.6% of the PCV patients, they had a improve in vision of 10.5 letters with monotherapy with aflibercept. And complete regression was observed in more than 50% of the patients. So these are all the studies which are just showing that monotherapy with aflibercept is very effective for the treatment of PCV. So this was another prospective studies by Jiris and Sugiyama. So as I said, most of the studies of PCV are done in Japanese eyes, and they have really done a very extensive study on PCV. And as we can see that aflibercept was well tolerated in these patients, and this is just a schematic picture which is showing. So these are all the polyps, and after 3 injections, it is showing a decrease in the number of the polyps, a decrease in the size of the polypoidal lesions, and OCT is showing a complete regression of the intraretinal fluid as well as the subretinal fluid. So again, Japanese case series, there are several studies which are done showing the efficacy of aflibercept monotherapy, which was done between 2014 and 15. I'll not go into the details of this. So this is a summary of all the studies, the PLANET study, the WALT, the Apollo studies, the Japanese case series. All of them have showed that that monotherapy with aflibercept for PCV is very effective. It helps in good regression of the polyps in approximately more than 30% of the patients, and 70 to 80% of the patients, they have a quiescent polyps. And the other studies, the ALTA studies and the VIEW 2 studies, they have shown that the duration of the aflibercept monotherapy can be extended to around more than 12 weeks to 16 weeks with monotherapy with aflibercept. So just to summarize this presentation, and then I will present 2 small cases. ICG is the gold standard for the diagnosis of PCV. Our main clinical focus is the visual outcome, not the polyp regression. And recent data, and these data that showed aflibercept monotherapy is very effective for the treatment of PCV and is very efficacious. So I just have 2 cases just for the panel for some discussion. So this was a 50-year-old male patient, female patient, who presented with a vision of 6/24 in the right eye. This was somewhere around in 2018. So this was the picture. You can see there is a large PED. There is a scarring here. This is probably a choroidal neovascular membrane. So this is the OCT which was done. There was a large PED with presence of subretinal fluid. And OCTA is done, or because of the PED, we are having the short shadow, but I can see a vascular network of AVN which is present here. I did an ICG, and ICG, the hotspots, the polyps can be seen. And along with that, a choroidal neovascular membrane is also appreciated. So this patient was in 2000, I think late 17 or early 2018, I gave 2 injections of ranibizumab. The vision, instead of improving, there was a decrease in 2 line. So the patient was lost to follow-up. And as you can see, the fluid has also increased. The PED height has also increased. The patient was lost to follow-up for 3 months, underwent PDT at some other center. And when the patient presented to me, the patient was almost same. There was even presence of this, some subretinal material is also there. The PED height is also the same. Subretinal fluid is there, and the vision also did not improve. That was the time when aflibercept came with that scheme of in which we could use. So I gave this patient 3 doses of aflibercept, and the vision improved to 6/12. And as you can see, the PED height has decreased. The fluid levels have also reduced, and the SHREM is also decreasing. However, again, COVID came. The vision has improved to 6/12. The patient was treat and extend. COVID came, and the patient was lost to follow-up, and then presented again after about a year without any injection. And there was a recurrence of the disease which was much worse than the previous visits. There is a hemorrhage which is present here. The PED height is there. All the fluid in the subretinal fluid has come, and these subretinal hyperreflective dots have also appeared. The SHREM has increased and the vision is present below by 6/60. So so this is just showing the ICG picture. The polyp size has increased. The BVN, the AVN network has increased. So the patient has worsened. So looking at this picture, I know this patient needs a treatment for a very long time. So I started this patient on aflibercept again after 3 injections. After 2 injections, the vision improved to 6/18. It is showing the absence of the hemorrhage. The AVN has regressed. The PED has come down, the fluid has gone down. So the patient is on treat and extend aflibercept. I have not shifted over any other medicines. The vision, best corrected vision is now 6/18. So my question, I just stop here and then I'll have a discussion on this. So this is my second case. I'm just presenting 2 peculiar cases. So this patient again had a PCV. On Octa, we can see there is presence of this AVN is present. So there is presence of this large PED with subretinal fluid the patient received. After 1 month of aflibercept, most of the subretinal fluid has decreased. The vision has improved from 6/24 to 6/12 parts. So after 3 loading doses of aflibercept, the vision had improved to 6/6 parts. I usually follow a treat and extend in these patients. I do not stop the treatment. I do not go to a PRN, although there was complete drying. So when I continued the treatment, the patient was on treat and extend 12 weekly. The vision is 6/6, and I decided to increase the duration. But in between treatment, being stable for about, I think, 3 12 weekly injections, after about 8 weeks from the last injection, fundus, and you can see that there is a hemorrhage which has appeared despite being on treatment. Although the PED height has increased, although there is not much activity in the intraretinal or the subretinal fluid, but because of this hemorrhage, the patient is presenting severe distortion. So unfortunately, I advised the patient to continue with treatment and to reduce the duration, but I lost this patient because the patient did not come with me and is receiving, although the patient is in contact with me and is receiving aflibercept only, but at some other center. So just my 2 doubts. So in the case 1, I know this patient will need treatment for a very long time. So for how long shall I treat this patient? And in second patient, despite having following the right protocol, the patient had a complication. So are there any markers in which we can we can have to prevent this complication? Although I think everything was going according to the book. So and how to proceed? We should continue with the same anti-VEGF. We should go to alternative anti-VEGF or PDT or whatever. Please, I would like Dr. Dinesh or any other from the panel to please answer. So thank you all for listening to me, and over to you, please, Dr. Alkesh.
Thank you, Bhuvan, for the beautiful presentation. And the question is directed to Dr. Dinesh Talwar.
Yeah, so basically, hi Bhuvan, nice to
Hi, sir. Hi, how are you?
missing you over here while we are having the snacks. So as far as period of treatment is concerned, normally on aflibercept, if you can reach 16 weeks treat and extend, and if you can get 2 consecutive intervals of 16 weeks, I think that's the time when you can stop treatment. And then but then that doesn't mean he doesn't come back. He still follows up on at least 2 monthly follow-up with you, but he can be on 16 weeks. Once he's had 2 episodes of 2 sequences of 16-week intervals, mostly they end up being in a resolution stage.
So that's what I think I typically follow. But these 2 cases which I have shown, so these are those patients which I think the second one especially, which was doing fine absolutely on 12 weekly. And when I was planning to make it 16 weekly, it bled on at 8 weeks. So I think these things will happen. We can't avoid it unless there is an answer to it.
Hi, Bhuvan. Shashank this side.
Hi, Shashank. How are you?
All good. In your last case, you have shown that everything is resolved, but there is still a PED there.
Yeah.
Right. So I was discussing with Gagan and sir also, like, do you still start chasing these PEDs with now faricimab and
See,
brolucizumab?
so Shashank, my protocol is for PCV especially, I follow a treat and extend approach. I'm very clear. Even if I see if once dried, so I would increase the duration 4 weekly normally. But after having these episodes, sometimes I would even like to increase it 2 weekly. So even if I've completely dried it, see, I've dried it after about 6 injections. I have achieved that complete drying. So I would not like to stop it. I will follow a treat and extend approach even in drying. And in some of these patients, after about a treat and extend for about 2 years, if the patient is really following up with me, 2 to 3 years, I sometimes even these PED, they completely disappear.
Now, Bhuvan,
I
that
got
is the
stopped.
question here actually. So, in your last case, as you shown that there is no intraretinal or subretinal fluid there, but there is
Yeah.
still a large PED there.
Yeah,
And
I
you
would,
tend to increase now and start treat and extend from there. Do you
yeah,
do
that I will, yeah, if there is no fluid, the vision is improved to 6/6, there is no intravitreal. See, the PED, I don't know will go away or not.
that?
I normally increase the duration.
So you do Octa there, you see this.
So you know, one thing at a time. First of all, you don't run after the PED.
Yeah. And you also
Regardless
don't
of the
run
drug.
after, sorry, and you don't even run after the membrane on Octa, because that will
Yeah,
not
I
work.
was going to come to that later on. But to answer you, to prevent those nasty surprises at 8 weeks and 10 weeks, my policy is that till the patient is on active treatment, his follow-up is always 4 weeks. The follow-up doesn't become treat and extend does not mean follow-up after 12 weeks. Treat and extend means injection will be given at 12 weeks, but the follow-up is still 4 weeks, so that you can assess whether any changes are occurring. And normally, like you said, you would probably see some changes starting to occur. So if you see some changes starting to occur, it may be then better to come from 12 back to 8. And most of the people, just remember this, people think that treat and extend means मैंने 4 किया, मैंने 6 किया, मैंने 8 किया, मैंने no, it is a back and forth process, right? So you will go up to 12 weeks, next time you're back at 8 weeks. Then again, you're at 8 weeks. For some time, you go to 10 weeks. You go to 12 weeks, come back to 10 weeks. Then you go to 16 weeks. But it is not a one-shot movement. It is not a steady movement. And that is what we must keep in mind. We shouldn't think, "Arey, isko to 12 weeks tha, ye 10 kaise ho gaya? 8 kaise ho gaya?" It will happen. And we have to keep that in mind. And which is why I don't believe, you see, in Western countries, their problem is coming for a visit is more of a problem than the injection. The injection is easier to take. For us, the injection is a painful thing. The cost of the injection is huge. As compared to that, the cost of a visit is not so much. So the visit is mandatory for weekly. You will not, it's not that this will never happen, but it will minimize the chances of this happening. Secondly, on Octa, what sort of Shashank said and then left and then you picked up. Octa is not used to decide whether to continue treatment. Now, hear that carefully, because it is not, it is meant to decide retreatment. For example, patient, you've done an Octa. Now, the next Octa still shows vessels. It doesn't mean it needs treatment. Those vessels are never going to go away. They are always there. But if within those vessels, you see development of some kind of brush borders, a little more density of the vessels in that area, in one particular area, this means there's a recurrence occurring. And this is an indication for treatment. So there's a very small, subtle change which will tell you on Octa that you need retreatment. But it is definitely not meant for deciding to give your next injection.
Okay. Thank you, Bhuvan, for the excellent presentation and beautiful discussion we had. And thank you, Dr. Dinesh, for clearing all the doubts put by Dr. Bhuvan. And now we'll go over to the last few minutes presentation by Dr. Alkesh Chaudhary. That is going to be a role of Bromfenac in macular edema, a case presentation.
So I'm just presenting a case of macular edema being treated with Bromfenac. Bromfenac is an NSA 0.9% clear solution used preoperatively to maintain preoperative dilatation, used to control MGD, used for allergic conjunctivitis, used for post-op pain, inflammation, especially with further steroid responders, used to treat post-op macular edema. So this is the OCT. Like you can see here, the clear this ring. So because of the early tapering of the steroids, there were blurring of the vision. So put on bromfenac drops. You can see this coming better, this improving, the other eye is normal. Again, this other eye was also operated. So started small macular edema, but both were put on bromfenac. You can see now this right eye has become almost normal now, clearly normal. Vision improved, which was blurred to 6 from 6 immediate post-op. It was blurred to 6:12, now back to 6 again in the right eye. Left eye, it was a minimal macular edema. 6 became 6 partial to 6:9. Now, next OCT, if you see, this is the latest last OCT, which was done, you see absolutely normal. This was just with the treatment of, with the help of bromfenac only. So Rajiv, do you have any comment on that? This, you can see this OCT, first OCT, blurring of vision, just treating with the bromfenac. Yeah.
Not sure how to compare these different NSAIDs.
Like we had ketorolac, now we have.
Yeah, because like bromfenac is a clear solution, is a less corneal toxicity that was being used. Just say my own experience.
So
just
I'm not
sharing.
using bromfenac, sir.
Okay. So, but they work like that. So these NSAIDs, they help definitely reducing the macular edema.
So, but
Yeah.
that depends what kind of macular edema we are talking about. Are we talking
Yeah,
about
early minimal macular edema,
inflammatory-
but leading to blurring of vision,
some
becoming normal.
inflammatory pathology in the anterior segment? Yes, probably yes.
Physiological, I didn't get.
So it can, but then it subsides on its own, right?
Yeah,
So what it does is basically what we were taught. and
maybe
I think it
some
releases
inflammatory portion. like
Whatever
there's more of it.
prostaglandins are released from the iris and uveal tissue, probably it inhibits that.
I think,
Yeah,
I think
Gagan.
one very clear indication that I follow for NSAIDs long term is obviously post-cataract CMEs. Definitely, I think if you start them earlier, then I think the chances of that happening is also lesser. The other main important role that I feel for NSAIDs is basically in diabetics who have very minimal amount of edema, very minimal amount.
Right.
And I think if you keep them,
That
if
helps
you
you.
improve their metabolic control and you keep them on NSAIDs, I think we can prevent an injection. No, no, it is, I mean, it is a bit confusing whether it's a metabolic control, but it does help. Definitely it decreases. That I have seen, I don't know how, but it does help.
My role for NSAID is in diabetic cases, when you operate cataract surgery, you start
that's
NSAIDs
again
along with
same-
steroids, so
same.
that.
That's right. It's basically for the prevention of
Prevention,
of CMA.
It does help.
If you
If you start them early and you carry them a little longer, it definitely doesn't happen.
So now actually we have been using in all our cases, cataract surgery cases, like we start on the first day itself and we continue for 3 to 4 weeks at least.
4 weeks is not enough. It's actually the problem starts after 3 weeks.
Yeah, it's
So if
after 3
you-
weeks. This was reported after 3
So
weeks.
actually, you should continue it for between 6 to 12 weeks. If you want to prevent it from coming up at all. And ideal is 3 months.
But should it be like, because normally,
course, because
normally if your cataract
in
surgery is
mild to
gone
moderate
smoothly well,
corneal toxicity
you
is
don't find
always
any
there.
reaction on the first day or second day or
Make it 6 weeks then.
6 weeks, yeah.
Uh,
It's only, I think, where
It
you,
is removed.
yeah,
The period when it is likely to happen goes away.
yeah.
So do we want to start it before the surgery?
Ideally, in diabetics, patients with inflammation, patients with uveitis, it should be 1 week before.
Yeah.
So one day before is in routine prophylaxis.
Right.
What about routine cases?
72 hours to 24 hours before the surgery.
Routine cases also?
It is used in routine cases. There's been that huge landmark study was there. So it is routinely being used, and because there's been this thing that, post-operative macular edema, depending fluoroscopically or otherwise, 4% to 33% was reported. And that's why they started saying that we should start off with these NSAIDs.
See,
That was really long way back.
No, no, that was in the present era of this thing, uneventful phacoemulsification. Will you recommend, because this
Yeah,
macular
so-
edema is self-resolving?
So what has happened is, previously it used to, when we were doing ICC, the reported incidence of fluorescein angiographically demonstrated CME was 100% on
100%.
day one,
Exactly.
right? We are no longer in that stage. With phaco, the incidence has gone down, but the point is your requirements have gone up. See, previously patient was happy with 612 vision. Now your patient is not happy with 612 vision. So because now even mild degrees of CME, you want to avoid. So your requirement is the same.
And especially if we are using these multifocals and
Yeah,
all.
अब
So
तुमने
they
multifocal दे
become
दिया तो
very
उसको
important.
mild CME हो गया.
Yeah.
Mild CME.
That it-
तो
it's gone.
जाएगा.
Yeah. So we normally start, what I do normally, I start 5 days before, and especially pre-operative, it's very important because then it prevents the pupillary constriction also. And definitely it reduces the inflammation. And of course, like it prevent the CME.
And last question from Rajiv and Shashank, our panelists. Gagan has come up with a lot of amazing things, and like if you're starting your retina practice and all those things, you may not be getting all those things. What minimum we can do the maximum?
Sir, Gagan has shown a slide, deeper and wider. So you need to have deeper and wider pockets to have. all
And I'm
deeper and
just saying
wider
ki how
imaging.
we can do a minimum.
So one
like,
thing
like he
coming
was,
to the science.
yeah.
So there are certain set of indications where definitely it
Yeah.
helps. So small pupil, definitely it is of help. Pediatric cases, definitely it is of help. But to think that every case we need a wide imaging, wide field imaging, this is not how the cases are to be managed. Most of the cases can still be managed with what traditional imaging we have. But yes, for a certain set of indications, we definitely need to depend on these cases. And if we don't have these for the better patient care, we should always refer it to higher centers and get it done wherever we feel it is required.
Actually,
Yeah, that. Yeah, that's the. And one thing more, I just add to that, if you have a indirect, you can attach a video system to that. So you can do all the periphery recording and you can show the.
You don't
patient,
need
like,
that. See,
in that case,
the fact is,
if you want to show to the patient.
no, even if you want to show to the patient, the fact is what he showed you was 7 fields. And the 7 fields this is a misrepresentation. These 7 fields were 30-degree fields. These were done for the ETDRS. These are not the conventional photo fundus camera which you use nowadays. The conventional fundus camera you use today is a 50-degree field. So your 7 fields is way beyond what you are getting in this. Okay. And if you ask the patient to move his eyes and you move the camera, you get most of the lesions that you see in an ultra wide field image, right? So even with the 7 field and all, actually what was the difference? The difference in clinically meaningful decision making was 4%. The difference in terms of lesions found was 11%. But 11% doesn't make a difference to what you're going to treat. What you're going to treat, the difference is in 4%. So that's all. And that is with the 7 fields. With the kind of imaging we are now talking about, that means you're asking the patient to look up and down sides. You can get most of the lesions which are there. You will not miss any clinically meaningful lesion, but you will miss all the photo essays and the awards for those photo essays in any journal, even the smallest one, right? So the journal, so those awards go to Gagan, but Shashank will manage to do effective treatment for all his patients.
And the last one.
I'll just summarize on that. So as Sir rightly said, so the current cameras that we have is around 50 degrees field. Rather, if you attach a lens to it, you can get up to 70 degrees. So that is, and there is a difference between wide field and ultra wide field. According to the FFA nomenclature, I think photography, I think ultra wide field is, they are talking about 200 degrees. And but we are achieving around 100 degrees. Now, definitely, as far as wide field imaging is concerned, there is scope for development, and there are certain very particular indications that it can be used for. As far as wide field OCTA is concerned, that's a different thing altogether. And as I had kind of indicated even in my talk, I think one of the most important things that I have learned with OCTA in my clinical practice is not AMD. It definitely helps, but it is CSR. Treatment of CSR and pachychoroid is something which has definitely changed the way I look at the retina through an OCT angiography. So that is one definite indication that I've picked up, and the other different pathologies like IJT and BEST that I had shown. As far as routine clinical practice is concerned, I think it is better to invest in an ICG, which is really getting downplayed, than investing in a wide field digital camera per se, like a Daytona or a California. OCTA definitely, I think, is a part of clinical practice nowadays everywhere, at least in the major cities. But then it is not the one and all thing that needs to be there.
And even in the OCTA, we have the OCT, we have the Heidelberg, which can go to 6 millimeters, but we use it all the way up to the equator by asking the patient to move his eyes.
Right.
Okay, you have to learn to explore the limits of the machine. But I'm not saying that it looks very nice. I mean, his images look much nicer than what mine look like. But I managed to get the information that I need for my patient. That's what I'm saying.
Yeah. Last question, like Dr. Sandhya's intravitreal injection, like bevacizumab, like getting multi-dose vial. How does we use and how to use? When can you just comment on that?
Definitely, it's a wonder drug.
Yeah.
It is as good as any other drug. As Dr. Diti said, that if you use it persistently long enough, it works as well as any other injection works in most of the cases. But there are issues, both logistics and both medical legal. So that we have to consider. We are losing out on this wonderful injection because of medical legal cases.
Because it is given already all over the world, like not in India, all over the world is being used.
To in various forums, and ultimately it's fall back on one particular individual. If I have a case, it's like me who has to fight with the patient in the law. It's like DOS or AIUS or some other society may not be able to help whatsoever they do or say. So that is the only thing that we have to like save our skin first. Otherwise, the drug is as good as any.
I think the proper way of making the injection aliquoting is very, very important. I think that standardized process has to be definitely followed. Obviously, medical legally, I mean, it is not FDA approved, so there are chances that you will at least get stuck. But then I think the general consensus of the forum would be supporting the medical fraternity about using it. But then obviously the process that you use and the setup that you're using to make the drug and give the drug also makes a very big, large, effect on the final medical legal aspect. And also, I think different countries are doing it in a different way. So I think we have to follow what is the prescribed norm by VRSI that we have here, and whatever those things has to be. I mean, yeah, I mean,
prescribed norm is as difficult to follow in individual practices. So that can only be followed in the institutes. But to practically, like I have used Avastin aliquoting 10 to 12 years without using this any grade 3 OTs and something, nothing has happened.
That's true.
So, but the guidelines are made such a way that
I have also used.
See, the fact is that the problem is not with the drug. Now the problem is basically about a dispensing pharmacy systems which we don't have.
Right.
I don't think any of these societies has actually done anything meaningful in this regard. Because, I mean, I'm not mincing my words. The thing is, you have to call a spade a spade. Either you say it works or you say it doesn't work. Now, if you make a rule which you know is not possible to follow, then it's over. And this is what is happening. Aliquoting in ampules, not possible. Aliquoting in syringes, what they are doing is wrong. Why? Because aliquoting being done in the Western countries is in polycarbonate syringes. These are not polycarbonate syringes. So again, we are not following that. So from that point of view, but practically speaking, has it made a difference? No. For a person who wants to give it, you have to, the only way to now give it is with a very good informed consent, in which you mention all these things. Our problem is that the vials which come in in India, it has written over there, it is not meant for intravitreal use. This is not an off-label problem. Vancomycin पे कहीं ये नहीं लिखा होता कि it's not for intravitreal use. अगर vancomycin के ऊपर भी वो लिख देते, not for intravitreal use, you could not give it for endophthalmitis also. The basic thing is here, they have written it is not for intravitreal use. They have written this can cause endophthalmitis if given intravitreally. So you have a problem. So if you explain all this to your patient, just like for brolucizumab, I'm explaining to them there's an added risk of inflammation. You want to give them Avastin, explain to them that, look, this is the cheapest product. You can't afford it, anything else, so we are giving this. If you can afford something else, these are the alternatives. And this is, this is the literature. But in the while, this is written, it is not for use. So that is the important thing, right? If that is there, there's no issue. A lot of people have stopped using it. And
Yeah.
it's very stopped
That's
using it
true. That's
for the
a
last 5
reason
years.
Because, yeah, I think.
Sure. Okay. So thank you all, and thank you all the speakers, our panelists, my coordinators here, and the international speakers also, and all the guests. Please, thank you very much, and for joining us in this beautiful evening. We had a superb presentation and superb discussion on retina. Learned a lot. I think everybody must have enriched their knowledge in retina today. So thank you very much. Thank you, all of you. Thank you. Thank you. Good night.